remaining. After 8 minutes, we're going to stop the screen sharing and then we have to move to the next speaker to keep it on time. So
Actually, we don't have many speakers, that way we can give little extra time.
we have, okay, so ma'am, in the total of 90 minutes, we've got exactly 10 speakers of 8 minutes. So ma'am,
Nine
we don't,
speakers.
is there anybody who's missing? Dr. Ruchi is
Nine
not.
speakers. Nine speakers are there, and we
I
have.
have a list. Okay, so I have a list of 10.
Okay,
Uh,
okay.
I don't know. Ruchi is going first. Ruchi Goel ma'am going first. Rachna Meel, followed by you're next, Dr. Neelam Pushkar, followed by Dr. Vikas Menon, then again Dr. M.S. Bajaj, Dr. Milind Changole, Dr. Seema Kashyap, Dr. Debraj Shome, and then Dr. Jyoti Batra, and last Dr. Mridula Mehta. 10
Okay.
each I have. So in 90 minutes, we've got 10 speakers. That's 80 minutes straightforward.
Okay. All
So
right.
we so we will have to keep it on time, ma'am.
Okay,
Otherwise,
okay.
next. Okay.
I think since
एक
I'll
सेकंड निखिल सर, बजाज सर ने ज्वाइन कर लिया है.
Okay. Wonderful. Dr. Vikas ने भी join कर लिया है. I can see Dr. Vikas as well. Can I request Dr. Vikas to please switch on the camera?
Hello,
Hi.
everybody. Hi, Dr.
Hello, sir.
Good.
How are you, sir? So we were just talking about how to keep it on time. That's very important because that's actually why I'm hired for. So
Okay, we are live. Start.
okay. I would like to invite everybody for the oncology session 1 that is going to be getting started. We've got the chairperson, we've got Dr. M.S. Bajaj, we've got the co-chairperson, Dr. Neelam Pushkar, we've got the convener, Dr. Ruchi Goyal, we've got co-convener, Dr. Rachna Meel, we've got the moderator, Dr. Vikas Menon. We've also got the panelists, Dr. Sahil Agarwal, Dr. Mridula Mehta, Dr. Jyoti Batra, and Dr. Milind Changole. I would request the moderator to please invite our first speaker, Dr. Rachna Meel, as Dr. Ruchi Goel is yet to log in. I request Dr. Rachna Meel to please start a screen sharing, and I request the moderators to please introduce the first speaker. Over to the moderators.
Uh, I would like to invite Dr. Rachna to be the first speaker of this session. Dr. Rachna is working at All India Institute of Medical Sciences and has a lot of experience with the topic that she's going to present, that is OSSN. We all are used to getting some very informative tips from her due to her vast experience with using various types of chemo reduction modalities in this disease. Dr. Rachna, please.
yeah, sure. I'm just trying to share. Just give me a second. It'll just take me a second, I think. Uh, so since we have just 8 minutes, so before I'm having some issues with sharing it. Just give me another minute or so.
First of all, open your PPT, ma'am, then share, ma'am.
I have opened it, only my I'm not able to. Okay, just a minute. I'm
Ma'am,
not
please
able.
close other applications.
Yes, okay. 1 second. The problem is I can't see the Zoom this thing. I can see my presentation, but the window which shows the Zoom window
Multi.
is very small. So yeah, yes, I got it. All right. I'm just gonna share this. Is it visible?
Not yet, ma'am. Now it is visible.
It's visible now.
Yeah, just put it
Okay.
on full screen mode and then the presentation mode, and then we can go ahead with it. Yes.
Is the presentation
Yes, ma'am. You can go ahead.
okay?
Atul, timer लगा दे.
Yes, okay. So today I will be talking about chemo reduction in ocular surface squamous neoplasia. Now, when we are talking about chemo reduction, what comes to our mind is usually the topical medication or topical chemotherapy that we use for chemo reduction in ocular surface squamous neoplasia. But today in this talk, I would be discussing about systemic chemotherapy and how it can be used in ocular surface squamous neoplasia. So I have no financial disclosures. All of us know that ocular surface squamous neoplasia is one of the most common ocular surface malignancies, and the incidence reported is 0.13 to 1.9 per 1 lakh population. And India being in an area which has a high solar radiation exposure, uh, sees pretty much higher numbers of this tumor, which has various manifestations, various morphological forms. And also, we are aware that this is one of the tumors which has a pretty high morbidity, mainly related to a high recurrence rate, which is again related to its multicentric nature, as well as the high chances of surgical margins being positive for disease, which may not be visible clinically, and therefore the role of frozen section in these tumors. We do see intraocular invasion around 10% of cases, and also orbital invasion in around 15% of cases. Metastasis is rare. So essentially, it's a disease which can have a pretty high morbidity due to the recurrences resulting into corneal opacity, symblepharon formation, and often, if it invades, requiring enucleation and exentration ultimately. So usually the treatment options that we know of and which are usually used to tackle this tumor are basically a wide local surgical excision with cryo of the margins, a no-touch technique, and brachytherapy in cases where it's invading into the adjacent walls of the eye, that is the sclera or the cornea. And also more popularly in non-invasive cases, we have topical treatment in the form of immunotherapy and also chemotherapy. But having said that, uh, there are certain grades of tumor where either of these approaches becomes very challenging. So if you have an advanced case of invasive ocular surface squamous neoplasia, and when I'm saying advanced, so it's not a definition that is being given or scientifically accepted anywhere. I'm just using it for this talk here today. And what I'm talking about is AJCC grade T4 tumor, so with the one that has an orbital extension, or a tumor which has extensive eyelid involvement with an extensive fornical involvement. So I will just give an illustration of some cases. We had this patient who came, this was a 45 years old male, and he had this huge involvement of the lid with a tumor that was arising from the ocular surface. You can see the pigmentation here on the ocular surface, and of course a huge papillary mass which is involving almost all of the lid, and also a more flatter invasion of the rest of the lid. So this is how this patient presented, and frankly speaking, surgery would have been very difficult in this case, and again topical treatment is not what you would prefer in a case of invasive OSSN. This is yet another case, a 65 years old male who presented to us with recurrent mass, which was involving the lateral canthal area going into the fornix. There was some limitation of movement in this eye, and there was also on imaging, you see there was the extension into the orbit. Now here, again, this is advanced invasive ocular surface squamous neoplasia. And like I said, that the conventional modality, which is surgical excision, may not be possible in this scenario because of the extent of the disease. So of course, and also if one would go ahead with a surgical excision, we are sure not to get a frozen section clearance of the tumor in such cases. So essentially, this remains a challenging case scenario where the options that we have for treatment do not work the way we want them to. So this was why we thought we will look up at the role of systemic chemotherapy, which is widely practiced in management of head and neck squamous cell malignancies. and also has been used in downstaging the tumor in islet sebaceous gland carcinomas. So we went ahead and a combination of paclitaxel and carboplatin was used for the treatment. Okay. All right. So this is a surprise. I think the animation did not work in this case. Anyways, so what I'm going to do is I will just probably try to put this on the side. And so now this patient, after having received 3 cycles of chemotherapy here, this is how the response was for the tumor. So it's essentially showing more than 90% regression, with what remains is just all right, yeah. A flattish residual mass on the palpebral surface. So it worked like magic in this case. And when we went ahead and we did an incision biopsy, what we did find out is that this was still showing invasion into the underlying conjunctival stroma. And so we went ahead with wide local excision, cry of the margins, and followed by a mucous membrane graft. And this is how the patient is at 2 years of follow-up. So you see the mucous membrane graft has taken up quite beautifully, and the patient is completely free of disease. So this was this case 1 that I wanted to show. And then there is the second case. Now, I have already shown you the pre-chemo pictures, and this is after 3 cycles. Am I audible? Because it's very difficult to make out if I'm still there.
You're audible, ma'am, and 1 minute remaining.
Yeah, okay. So I'll just wind up quickly. So this is the second case. And again, you can see it has completely disappeared. We did not need to do any surgery in this case. The orbital component has gone away. Yet another case, we did go ahead and publish our results in the 5 cases, where 4 out of 5 cases showed a wonderful response to treatment, except 1 did not respond at all and required an exenteration later. So I would like to conclude saying that systemic chemotherapy may be tried in selected cases of OSSN with extensive eyelid invasion or an early orbital invasion. And it can be helpful in preventing avoiding adjuvant radiotherapy, even in cases with early orbital invasion. It's a little early to say. We need to see more cases, do a little longer follow-up in these cases, but it seems to be a promising option. Thank you.
I request the moderator to either invite the next speaker. We are planning to have the question and answers at the end of all the speakers. If that's okay with you, sir, needed your approval on this.
Okay. Fine. So we'll take questions at the end if there is time. Next, I would like to invite Dr. Ruchi, who's here. Dr. Ruchi is a professor at Maulana Azad Medical College, and she would be talking about lid reconstruction simplified. Dr. Ruchi, please.
Yeah, good afternoon, everyone. And I'm sorry I was a little late. Rachna, have you stopped sharing screen?
Yes, ma'am. We just need you to start your screen sharing.
Yeah, okay.
Just since your screen is getting started, let me just remind you, we're going to stop the screen sharing at 8 minutes. We're going to give you a warning at 7 minutes.
Yeah.
If we can see your screen, just put it in presentation mode and you're ready to go.
I think you can see it.
Yes, ma'am. You're okay. You can get started.
Okay. So whenever we have a patient, it is not just the extent of the defect that one has to ascertain, but one has to see the adjacent areas like lid margin, the canthal tendons, lacrimal drainage system, the septum, and the condition of the levator aponeurosis. Now, what is a small defect for an older patient may be a large defect for a younger patient, because there is very little laxity of skin in young patients. So one has to be careful when we are dealing with a large defect, because there, instead of direct closure, we may need grafts or flaps. Now, just to recapitulate the relevant anatomy, whenever we are doing any kind of lid reconstruction, we'll be talking in terms of the anterior and the posterior lamella. The anterior lamella is the skin and the orbicularis, and the posterior lamella is the tarsus and the conjunctiva. The other important thing is the superior tarsus is about 10 to 12 millimeter in vertical length, and there are two vascular arcades that we can rank upon, whereas in the lower lid, the tarsus is 4 millimeter in vertical length, and we just have one vascular arcade, and that is situated at the inferior border of the tarsus. So if we have to take a full thickness string graft, that is to construct the anterior lamella, the preferred sites would be the upper lid, where we have some amount of redundant skin, the post-auricular area, and the supraclavicular area. Of course, there are many other sites, but these are the preferred sites because the skin is thin in the upper lid, and it has a very good match if we use it. For the posterior lamellar reconstruction, we need cartilaginous grafts. The preferred site again would be a nasal mucoperichondrium, where we are going to get both the substitute for conjunctiva as well as the tarsus. Then you can use hard palate. Otherwise, you can use a combination of auricular cartilage and a buccal mucosal graft, which is very commonly used by most of us. Now, another thing to remember is the skin incisions on the upper lid need to be parallel to the lid margin, whereas in the lower lid, we need to make perpendicular incisions so that to avoid ectropion. And at the end of the surgery, whenever we are doing a closure, we need to leave the lid a little everted to prevent post-operative wound contracture once the edema subsides. Now, the techniques that are mostly used are the primary repair by direct closure, and we can augment it with lateral cantholysis. Then there would be lid sharing techniques and composite grafts. So let's go to each of them one by one. Now, whenever we have technique is used, of course, for both upper and lower lids, and defects up to less than or equal to 1/3 of horizontal length, these are closed, and a vertical mattress suture is first passed. This is a 6-0 silk suture being passed from the gray line, and this is a vertical mattress suture. Different patterns can be used. This is 3 millimeter on one side, then coming out at 3, going back at 1 and coming back at 1, and tight like this, leaving the outpouting at the end of the surgery. Then you can pass a suture from the posterior margin and the anterior margin. Important thing is that these ends have to be left long so that they don't irritate the cornea. The tarsus has to be sutured with a absorbable suture, and these sutures have to be kept a little longer to be kept away from the cornea. Now, Tensel's semicircular flap is another easy procedure and very commonly performed, and any defect which is about 40% in size can be repaired by Tensel's semicircular flap. This is just an example. Here you can see an upper lid coloboma, and this has been repaired by Tensel's flap. So what we do is, so this is a semicircular flap which has been prepared, and here the vertical length is more than the horizontal length. Now these dimensions are not to be practiced like this can be varied depending on the size of the effect, but the vertical should be longer than the horizontal. After creating a flap, we do again a lateral cantholysis. The tissues are approximated, and this is how you create the lateral canthus. This is being the lateral part of the tarsus is being sutured onto the periosteum, and it is tied together. And then after that, lot of undermining is done, and the flap is approximated. So this works really well for about 40% lid defects for both upper and the lower lids. Now, to reconstruct the upper lid, pedicle flap can be used from the lower lid. The advantage is that in the upper lid, the absence of lashes with other procedures is sometimes very bothersome. So if you use the pedicle flap, the upper lid in the post-op phase will have the lashes. The only disadvantage is that it is a little tedious, and again a 2-stage procedure wherein you separate the upper and the lower lid after 6 weeks. Hevis flap is used whenever we have shallow defects in the lower lid, and in this what we use is we utilize the tarsoconjunctiva of the upper lip and just reflect it downwards, And this is an example, and these are done for defects which are less than 50% of the horizontal length of the eyelid and shallow in nature. So this was a nodulo-ulcerated lesion which came out to be actually a squamous cell carcinoma, and this was present laterally, and there's a lot of undermining has been done, and a strip of tarsus was created, and this is what you can see over here. A flap has been created from a tarsoconjunctiva of the upper lid. It is being sutured to the lateral end of the tarsus of the lower lid, and the same end flap has been pulled and tied on to the the periosteum of the lateral tubercle, so that we are able to construct the lateral canthal ankle. And this is again a very useful procedure for shallow defects and very easy to do, and you can utilize the vascular supply being again, as I mentioned, there are two arcades, and you can utilize that. So this is a Hevis flap. Now for defects like this in the lower lid, this is
1 minute remaining, ma'am.
Okay, so we can use a Hughes flap where you again use a tarsoconjunctiva of the upper lid, and it is being used to reconstruct the lower lid. So this is the lateral cantholysis being done, and this is the tarsoconjunctival flap from the upper lid which is transposed to the lower lid. So this is again a two-stage procedure. It has a very good outcome and gives very good results. Whereas in Cutler bed, where more than mostly for central defects and large vertical defects, you take full thickness flap from the lower lid, and this is being transposed to the upper lid. Again, after 6 to 8 weeks, you divide them. So I will just skip these videos. The disadvantage again is that this is a two-stage procedure, and you cannot use it in unilateral cases and in children where it can cause amblyopia. Then there can be flaps from the forehead, or you can use the flaps from temporal area. Again, very good results are obtained. And these are for very large defects of the lower lid. That Mastardi's cheese rotational flap is being used. And so sometimes you just leave it unsutured. So to conclude, only for lower lid, you can use a Hughes flap, and this is the tarsoconjunctival flap, or the inverse Cutler bed. For shallow defects, a Hevis flap. Large skin defects, you can use for the lower lid, you can use Mastardi's cheek rotational flap. For the upper lid, the Cutler bed really works well. And for procedures for both upper and lower lid, a direct closure for about 1/3 defect, tensils for 40% defects, and a temporal Frickle flap can be used for both upper and lower lid whenever there is skin shortening. Thank you so much.
Thank you, Dr. Ruchi. That was a difficult task to actually compress everything in 8 minutes, but you managed to do it very well. May I just ask the esteemed chairpersons for just one comment or one question we'll take, and then we proceed on to the next.
Yeah, so hello, Dr. Vikas, how are you?
Hi, sir. Hello, sir.
Good. So Dr. Ruchi has really, given a very comprehensive, sort of a talk about all the procedures. I just wanted to add one small comment that sometimes, you can combine two procedures also. For example, if you have a large coloboma, which is more towards the lateral side, you can combine a Cutler beard with the lateral advancement flap. And so our audience should go away with this little flexible attitude that you can combine procedures. You can have a plan B on the OT table. Don't try to stick to whatever you thought that you'll do. Sometimes the case can spring a surprise, and you might have to modify your plan. Thank you.
Very well said, sir. So with that, we move on to the next talk. And in the interest of time, we are skipping questions right now. And if we have time at the end, we'll take them. May I invite Dr. Neelam Pushkar, who is again a professor at Dr. R.P. Center, All India Institute of Medical Sciences, to please enlighten us on the management of eyelid retraction, a case-based approach.
Can you see my slide?
No, we could see it earlier, but now we can't. So could you please reshare it, ma'am?
Reshare. Okay.
एक बार वापस से वही प्रोसेस करना है आपको.
एक मिनट. Okay. Let me just do it.
Yes, ma'am. We can see it. Just presentation mode and we are ready to go.
Okay.
Yes, ma'am,
Good
you're on.
afternoon, everyone. I'll be talking about management of eyelid retraction. So we know eyelid retraction is defined as asymmetry more than 1 mm in eyelid position and or presence of scleral show. You can see here typical patient of thyroid eye disease with eyelid retraction and lateral flare, which is basically a pathognomic sign of thyroid eye disease. This is another patient who presented since birth, he had this problem. So this was a congenital lid retraction with high myopia. That's why pseudoproptosis like picture is seen here. So talking about the causes, we all know thyroid eye disease is the commonest cause, but we have congenital causes. We can have lid retraction following ptosis surgery. It can be because of compensatory lid retraction or some cicatrizing condition. So evaluation of a case is very important to look for the underlying cause, and we should try to see whether the lid position is stabilized or not, especially in patient with a thyroid eye disease. Then grading of eyelid retraction is very important, which helps in the management. So grading for the upper lid, mild retraction is 1 to 2 mm, moderate is 2 to 5, severe is more than 5. For lower eyelid, it is different. Mild is 1 to 2 mm, moderate retraction is 3 mm, and severe is more than 3 mm. So for the management purpose, it's important that we understand that the eyelid, especially in the upper part, is divided into 3 lamellae: anterior lamella, posterior, and the middle lamella. So anterior lamellar pathology, we know anterior lamella is the skin muscle layer. So any trauma, burn, or chronic dermatitis can primarily present with ectropion, but can have associated lid retraction also, as you can see in this particular lady with the anterior lamellar cicatrization. So in such patients, what we have to do is to augment this skin with the help of a grafting procedure, as was done in this patient. You can appreciate the graft here, both eyes after surgery. The graft was taken from the post-auricular area. So that is how we treat such patient. Then patients with posterior lamellar pathologies, we know that posterior lamella is the tarsoconjunctival layer. And whenever there is shortening, it's mostly because of Stevens-Johnson syndrome in younger population. And in older, we see trachoma as a commonest cause for cicatrization of the tarsoconjunctival layer. So we know that these patients, though primarily present with entropion, but sometimes they can have associated lid retraction. So the management in this is to augment the posterior lamella. As you can see in the image here, this is how we place and augment the posterior lamella. And the commonest graft used is the mucous membrane graft from the lip, though other grafts are also described. Middle lamellar pathology, we should understand the middle lamella in the upper lid is the levator mullus complex with septum, and lower lid it is inferior retractors with septum. The commonest cause is thyroid eye disease, though it can result from ptosis surgery or following trauma. This is typical case, again, thyroid eye disease. This is a patient with overcorrected ptosis in right eye. So surgical management for middle lamella lengthening for mild retraction, you can get away by a minimal procedure, just do LPS weakening or Muller's excision, or you can recess the LPS little bit. And if there is lateral flare, you have to cut the lateral horn also. For moderate retraction, generally you need a combination of these surgeries, or you can do marginal levator marginal myotomy, or you can do recession with cutting of the horns. Cutting horns is important in moderate retraction. With adjustable sutures you can use. Severe retraction patients, that mean more than 5 millimeter of retraction, you have to in addition place a spacer for a predictable results. Transverse blepharotomy is a procedure which is classically described for severe retraction in cases with thyroid eye disease. So now coming to specific entities, talking about thyroid eye lid retraction, you see a typical lateral flare in these patients. This is a patient who had acquired retraction, was euthyroid at presentation, 2 millimeter of retraction you can see in the mid-pupillary area. So in this patient, Muller's excision was done, and we know that Muller's excision will take care of, say, 2 millimeter of lid retraction. So here you can see the Muller's muscle has been reflected and it's been excised. And here you see the cutting of the lateral horn. The cutting has to be full thickness and proper, taking care of the lacrimal gland. Post-op, generally we see severe ptosis in these patients, but generally the lid position stabilizes by 1 to 2 months. So we also know that in thyroid eye disease, we should wait for the lid to stabilize. Generally say, I prefer waiting for 1 year. And because we know that there can be resolution of lid retraction in these patients. So during that waiting period, you can consider injection Botox. So around 5 unit to 15 unit can be injected depending on the amount of lid retraction and lateral flare. It is injected in the midline and on the lateral side, depending on the amount of lateral flare, we have to decide the dosage of the Botox. And it's a temporary procedure. We should remember that. Sometimes in patient with acute congestive lid retraction and proptosis, we even have to do tarsorrhaphy as a temporary procedure. Coming to overcorrected ptosis, now in this patient, you can see this is right eye overcorrected by 2 millimeters. And if you see closely, you can even see the blepharochalasis kind of fold. This is mainly because the incision given was very close to the lid margin. That's why there was a lid fold formation like this. So in this particular patient, I had to tackle two problems. One was the lid retraction 2 millimeter and shifting of the lid crease from 3 mm to 5 mm. So this is a short video, very simple procedure where tarsomyotomy with recession of levator was done 4 millimeters. So this is conjunctival approach. I'm trying to see the upper border of the, tarsus. Now this is with the blade. Partial thickness cut is given 1 to 2 millimeter from the superior border. It's better to have a partial thickness first, and then we can make it, full thickness, taking care of the underlying muscle, which is the aponeurosis. Now, since this was a ptosis operated patient, so like we expect the aponeurosis just beneath the tarsus somewhere. So after exposing, you have to dissect a plane between the aponeurosis and the orbicularis. And there was scarring in this because this was operator's ptosis patient. So I have to do some sharp dissection using blade. So
1 minute remaining, ma'am.
okay, all right. So so 3 sutures were passed, and finally this is the post-op picture. Another interesting video I would like to show then. I'll skip my slides then, if only 1 minute is left. So this is another patient of congenital, and spacers, we know that there are several spacers described in the literature. I'll skip these slides. This is the mucosal graft was used in these patients to correct the lid retraction in severe patients with severe retraction. This is how mucous membrane graft is placed between the aponeurosis. We suture it and then we suture this to the tarsal surface. I have an interesting video to show. If you can provide me 2 minutes, please. So this is a child with congenital orbital fibrosis, a very rare entity, in which there was, upper lid pseudo retraction, fixed glow with a tight inferior retractors and rectus muscle. So the inferior rectus recession was done, and now I am doing inferior retractor disinsertion. So you can see very deep fornix here, and you can even appreciate the fibrosis and thin conjunctiva. The conjunctiva was not very healthy in this patient. And so the conjunctiva I am cutting from the lower, separating from the lower tarsal border. And there's a lot of dense fibrosis, which you can see. So creating plane was difficult between the retractors and the conjunctiva. But I dissected it nicely with the blunt and, sharp dissection. I completely freed the conjunctiva. A biopsy was done, which showed fibrosis. Then I went ahead with...
Ma'am, I'm sorry, but the time is up. If you could sum it up in the next 30 seconds, please.
Okay, so I just want to show this video. So now next what I am doing here is that I'll separate the retractors from the orbicularis muscle. And then it was completely disinserted. And then everting, this is the retractor here in between, completely disinserted. And then everting sutures I have passed. And this was the post-op picture. You can see the upper lid got automatically corrected because of inferior rectus muscle recession, and the lower lid correction was done by the retractor disinsertion and everting sutures. So complications we should remember can happen. This is like lateral flare is persisting in this particular patient. So take-home message is that the management of eyelid retraction depends on the amount of retraction, etiology, and lamella affected. And it's important that we explain the possible complications to the patient. Thank you so much.
Thank you.
Thank you, ma'am. That was really interesting.
Yes, yes. I think Vikas, I will take over since I think you have to present next. So yes, let me have the honor to invite Dr. Vikas Menon. He's a dynamic academician and also a wonderful oculoplasty and oncology surgeon. He's working at Center for Sight, and I think he's going to talk about orbital fractures raising the bar. Over to you, Dr. Vikas.
There's a change, Dr. Rachna. I've moved to Chennai and I'm at
I'm
Arvind Eye Hospital now.
I'm really sorry. I'm really sorry.
That's okay.
That's news to me. Okay.
Center for Sight is also part of me. It's been there for a long time.
Yes.
Yes. So,
I apologize. Yeah.
can you see my slides? Yes. Okay. So my slides are visible?
Yes, sir.
Yes, sir.
Okay. So I'll be briefly talking about orbital fractures and what I have recently learned over the years as my understanding has improved with this entity. So number one, I don't have any financial disclosures about any implants or any equipment that I'm talking about. So basically, we all know that fractures can affect the orbit and can lead to the disruption of any of the walls of the orbit. It can be roof, floor, medial wall, lateral wall, any of them, depending upon the impact and the severity of the injury. But what we most often see is the medial wall or the floor of the orbit getting fractured, as these are the weakest walls of the orbit, and any blunt trauma can cause direct or indirect injury to these walls. Now, a patient classically coming after trauma to you with swelling, ecchymosis, globe dystopia, or motility disorders or restriction of movement mandates a CT scan to rule out an orbital fracture. And so when we see or identify an orbital fracture on a CT scan, what comes to our mind, and we quickly plan out the management. So what we think about is, I'm just going to expose the floor. And then after that, what I'll do is I'll release the entrapped or prolapsed muscles and soft tissues and fat, whatever are prolapsed into the sinus and then towards the orbit side. And then I'll cover the defect with an implant and do an FDT quickly to see that everything is free and there is no residual entrapment, and then closure of the incision, and that should be all. So that's how our mental framework works when we see a fracture patient and or when we are going in for a fracture surgery. But my question here is this enough? Let us see a few examples. Now, this patient had undergone an orbital fracture surgery somewhere else, and you can see a lot of scarring in the medial canthus and in the lower eyelid, and not shown in the picture, but then she had the restriction of the upgaze as well. So when an imaging was performed for this patient, you can see something abnormal here. And the abnormality is that the surgeon has placed a titanium implant, but the position, look at the position of the implant. So the implant is rising superiorly, medially, and on the sagittal sections of the CT scan, you can see that the plate is actually interfering with the inferior rectus muscle and causing more damage than probably patient would have had from the surgery, from before the surgery by the trauma. So surgery here has become more traumatic than the original trauma itself. Another young patient who presented after fracture repair surgery, and he was not very happy. And if you look at him closely, you will understand why he would not be very happy, because of the size difference in the size of eyes. He said that he had enough ophthalmos before the surgery, but even after surgery, he's persisting with difference in the size of the eye. That is the complaint of the patient. So when an imaging was performed for this patient, you can see how the implant is placed. So you see the sagittal sections, and fortunately it's a titanium implant, which is easy to see in post-op scans, whereas sometimes we have these porous implants, which are not so easily seen in the CT scans, but fortunately with titanium, we can do that. So you look at the implant. So what is happening is that, and look at the coronals. So what is happening is that the implant is positioned relatively inferiorly compared to the normal orbital anatomy. So where the implant should have been here, rather the implant is positioned lower down. So although the defect is covered, the defect of the floor is covered nicely, but it is not adequate. As a result, the patient is not satisfied because the implant is not positioned properly And this is actually not an ideal kind of result that we would desire. Although the defect is covered, there is no prolapse of tissues, that part is taken care of, but still, particularly in young patients, this is not the kind of result that we would desire. So what we have understood over the years is that it is not only important to just cover the defect with something, but rather to restore the anatomy to the normal as much as possible. So two major landmarks which help us to achieve that purpose are, number one is the inferior-medial orbital strut, which is a dense bone here in the inferior-medial orbit. And the other is the posterior ledge, which is formed by a part of palatine bone forming a part of the orbital floor. Now, these two structures are relatively rigid compared to the rest of the orbital bones. And even if there is a big fracture, most often you will see that the inferior medial orbital strut remains intact and the palatine bone or the posterior ledge remain intact. Now, what we do is we use these two landmarks as for our reconstruction. So we use them to place our implants properly. And we'll see in the coming slides how this makes a difference. Now, this patient had a bad trauma, bad fracture of the inferior wall and medial wall of the orbit, underwent repair somewhere else. There is an implant here in position. You can see that, it's not very clear, but there's also, you can look at the superior orbital sulcus and it's deep compared to the other side. Patient has bilateral sixth nerve palsy, which I would ask you to ignore for a moment, because that's not really related to the fracture what we are talking about here. Now, this patient underwent a revision surgery and a preformed orbital plate was placed. Now, you can see here how the result is different from what the previous plate that was placed initially. So you can see that here the medial wall is left unaddressed and the orbital floor posteriorly, the fracture is still there, the gap is still there, whereas now, look at the sagittal sections, that the implant is placed properly, covering through the defect, the entire extent of the defect of the floor going up to the posterior ledge, and also the medial wall is sufficiently covered. Medial defect is sufficiently covered, and if you compare it with the other side, the orbital volume restoration is much better and much closer to the normal side. And look at the superior orbital sulcus. So you can see here that the sulcus is much better now, and the sixth nerve palsy requires another sort of management, which I'm not covering here. Another patient having a large orbital floor fracture, you can see on the sagittal scans, begin to appreciate this palatine bone portion or the posterior ledge. And you see that it is the frontal section, but the patient complained of enophthalmos, which is not very evident here in this photograph. We'll see in the next ones. So you see, this is the patient after the scan. So the advantage of using titanium plates is that we can get good post-op imaging, and we can see whether our implant is in proper position or not. So this patient, you see from the worm's eye view, and you see the enophthalmos on the left, corrected by the correct placement of the implant in the post-op photograph. Another patient with the enophthalmos on the right side, corrected by the proper placement of the implant. Another patient having good results after correction properly and adequate placement of the implant on the floor. Now, how we can further improve our management is by using tech. We have a navigation system, Stryker navigation system in our hospital here. What this does is it provides us information intraoperatively whether we have placed the implant correctly or not on the posterior ledge or not, whether the medial wall is covered appropriately or not. So that is one advantage of using navigation, because even in the hands of experts, sometimes intraoperatively, when there is so much of trauma, there's a lot of deformity, it's not exactly possible to make out where you are placing the implant, which navigation helps you to do intraoperatively.
I'm sorry, sir, but the time is up.
Lastly, there are newer materials, and particularly absorbable implants I would like to mention, which are very helpful in pediatric fractures, where there is a blowout fracture and there is incarceration of the tissue. Here, you don't need actually a more permanent kind of an implant. You just need to reduce the fracture, the soft tissue contents, the muscles to be released, and an absorbable implant works very well for pediatric age group. And then there are patient-specific implants in complex fractures like these, where there's a cranial fracture and there's a very bad fracture here. So you have patient-specific implants which are formatted and made as per the patient's requirement, matching the other normal sized orbit as far as possible. So these are few of the things which we are doing now, which we have learned over a period of time. and to highlight the fact that it's not just about covering the bony defect anymore, and our aim should be restoration of the anatomy. And the newer technology, intraop navigation, etc., are giving us, are helping us a lot in getting better results and improving our patient outcomes. Thank you very much.
Thank you, Dr. Vikas. It was very interesting and wonderful. I think we'll take questions at the end. I'm sure there'll be a lot of questions regarding the fracture repair.
Yes, ma'am.
Presentation. May I now invite Professor M.S. Bajaj. Sir is head of oculoplasty and orbital tumors at RP Center. And sir will be talking about minimally invasive approach for orbital venolymphatic malformation.
We can see your screen, sir. If you could just put it in the screen share, the presentation mode, we can go ahead.
Can you see it now?
Yes, yes, sir. We can go ahead, sir.
Okay. So I'm just going to share our experience with a very important clinical entity, a very challenging entity of orbital lymphatic malformations. And
we can't hear you very
The
well.
audio is
I'm not
less
sure
there.
if everyone is able to
Just
hear
my mic, I guess. Can you hear me now?
Yes, sir. Loud and clear. You can go ahead.
Okay, good. So the management of which has changed over the past few years, and our orbital, these very, I think the upper part of the screen is getting obliterated by this. Is it? The upper part of the screen, is it visible to you? The header of the title of the slide?
Yes, sir. Yes, sir.
Okay. So these malformations, venous malformations and the venolymphatic malformations, they is a spectrum of these diseases depending on whether they are purely venous or purely lymphatic or in between venolymphatic, and also depending on the amount of blood flow, that is where it's a slow flow or a high flow malformation. So now lymphatic malformations are usually congenital slow flow malformations, and they are due to the abnormal development of the lymphatic system. So now these venolymphatic malformations are conventionally also called as orbital lymphangiomas, and now they're, according to their classification, they can either be classified as macrocystic, microcystic, or mixed, depending on their cyst size. Now, this is I can't see that upper part of my slide. Is it something that
we can see the whole screen, sir?
Okay, so there is this little upper, thing, that control window which has come up. All right, never mind. So this is a imaging picture of a microcystic lymphangioma. You can see that the cyst size in this is not, it's so small that you can hardly visualize the cyst there. And the current treatment options which were initially, surgery was the usual treatment option. We were debulking these lesions. And the problem was that it was quite a messy affair. We were not able to, remove the entire lesion. And because of its it was interwoven with the vital structures of orbit, it was potentially dangerous also. So the other short-term intervention was systemic steroids for any intralesional bleeds or any acute exacerbation. And then came up the sclerosing agents. There's a huge list of sclerosing agents with their pros and cons. So pisibelin is usually the gold standard which one could use, but because of its cost and lack of availability, it may be a restricting factor. So in our scenario, either bleomycin or pingyangmycin, which is a derivative of bleomycin, were also tried as an alternative to these. So like I said, they pose a therapeutic challenge because of the infiltrating nature, and surgical management of these lesions is fraught with danger. So sclerosing agents do cause, theoretically, they are known to cause some side effects, but in the dose that we use for the orbital component, these are not seen with that kind of dose. It's a non-invasive procedure, and since bleomycin is easily available and quite economical, it is a suitable alternative, a very suitable alternative in our clinical scenario. So these are the various mechanisms of action which are listed for how it works. The main being that causing endothelial destruction and then fibrosis and obliteration of the lumen, or you have either a oxidative damage or it causing apoptosis. And the intralesional bleomycin therapy, which we were using, was at a concentration of 1 international unit per ml mixed with lignocaine, and with a 23 gauge needle deep inside the lesion with real-time ultrasound guidance. And in macrocystic variety, usually you will be able to get a aspirate of the contents. So you can, inject a volume equal to the aspirated contents. But in mixed and microcystic varieties, you might get a dry tap. So you can inject a volume which is not more than 5 ml into the orbit, which is quite safe to inject. All right, so this is a short video of the procedure. Like this is that we are doing it under ultrasonic real-time ultrasound guidance, as both a B and a scan guidance. And then after that, after introducing the needle, depending on your imaging, the location of the lesion, and then manipulating the lesion to get the best amount of your aspirate. And after that, you can just go ahead and inject the bleomycin equivalent to the amount of fluid that was aspirated. This was these are the parameters that were used for the pre-op evaluation, clinical and both investigative evaluation of the patient, and then a color Doppler wherever needed. And MRI was used preferably for the imaging and also the volumetry. And this is just a, I'm showing you the various salient cases that were there in the study. This was a pre-injection picture, and then after injection in the first case, you can see that it was a macrocystic lymphangioma with a fluid level inside. And then after the injection, you can see that a gross reduction in the size of the lesion. Another case, pre-injection and then the post-injection picture. Again, you can see these are the pre-injection pictures showing a large lesion inside the orbit. And these three are the post-injection pictures where you can see a significant reduction of the size, which is also reflected in the clinical picture. Another case of a macrocystic lymphangioma. Again, the pre and the post-injection pictures showing a gross reduction. I'll just quickly skip through these slides. And here also you can see the patient pre and post-injection. Another on imaging a post macrocystic lymphangioma. Another case of a microcystic lesion.
Apologies, sir, but the time is up.
We're almost through. Huh? Just this last few slides. So very few complications were noticed, like chemosis, conjunctival chemosis, skin discoloration in some cases, and subconjunctival hemorrhage. And to conclude, bleomycin was found to be a safe and effective agent to cause reduction in the manifestations of orbital lymphangioma. And it should be considered as a first-line management of these lesions. And you can repeat the injections at an interval of 4 to 6 weeks. Being a minimally invasive procedure, it obviates the need for surgical intervention, which would be maybe partially effective and could be site-threatening. Thank you for your attention.
Thank you, sir. Can I request the moderator to invite our next speaker, Dr. Milind? Yes, we can see your screen, Dr. Milind. If you could just put it in the screen sharing mode. Dr. Rachel, I believe you're about to say something. Dr. Rachna?
Yes.
Dr.
So,
Rachna, I believe you're...
yes,
Hi.
I'm audible. I wanted to invite Dr. Milind for his talk here. He I was trained with us, and I think he has a wonderful approach to oculoplasty, and has a very interesting topic that he'll be talking about. That's congenital and ophthalmic socket. Let's build Taj Mahal. So let's do it.
Sir, please unmute yourself.
Dr. Milind, you can go ahead, sir.
Okay, good afternoon, everybody. My seniors, all. It's happy to see you all and hear to all. So, with due all respect, we all know that we are the best one, know the importance of eye, and as we are the eye surgeon, it becomes very important, especially in the children, where apart from vision and development, eye also stimulate the growth of the orbit and midface. If there is no eye or very small eye, the we get a small bony orbit. There is a constricted mucosal socket, short eyelid, reduction of palpebral feature, and loss of malar prominence and midfacial anomalies. So it becomes tricky, and the condition is we all know as a congenital anophthalmos, where there is no eye. So early detection and intervention is the key factor. Generally, grossly, I divided it into two parts, like that is eyelid anomalies with anophthalmos and eyelid and without any eyelid anomalies. They are sometimes associated with many syndromic association and systemic malformation. So we have to thoroughly evaluate such child for their management. So it is difficult to manage from the prospect of ophthalmologist and from the prospect of parents, but we have to do something. So these are common questions people ask me while managing the anophthalmic socket. First and foremost is whether we should do imaging. So there is, it gives you rough idea about periocular structure, presence or absence of cyst or eyeball, and also gives you a clue about any other abnormality present. But it's not necessary, especially because MRI needs anesthesia and CT leads to a radiation exposure. But you can document anophthalmos by merely doing a orbital ultrasound. And later on, you can do MRI and CT depending upon the need of management. The second question people generally ask when to intervene. So it depends upon the mainly laterality. If bilateral, then one can wait. If it is unilateral, it's better to undergo early intervention. Age, as I told you, early to intervene will have a better cosmetic functions. And globe status, yeah. Anophthalmos is absent of globe. If there is a small amount of microphthalmic globe, one can wait for some time and see for the growth and visual potential and then subsequently manage. Factor we generally consider, as I told you, is the status of eye, severity of volume, age of child, and most and foremost is psychological support and the system the child is having. So generally approach is stretch, stretch, stretch. So we stretch the conjunctival sac, then we stretch the orbit, then sac, then orbit, and so on, depending upon until and unless you get a desired effect. Most of the orbital growth of the child takes place in first 2 years, 70 to 80%, and you have to intervene in that period, which is essential. So generally there are two type of intervention. One is static intervention, one is dynamic intervention. What is static intervention? That we put a serial enlarging conformer or implant and Once there is a sufficient growth, we replace it with another larger number or larger volume implant and conformer. We can use directly a prosthetic eye, but the number of surgeries increases, though it is relatively cost-effective procedure. Like in this case, the child present at the age of 3 months will subsequently do enlarging conformer, and once we get a sufficient size of eyelid, we put an implant in the orbit, and subsequently the conformer is replaced by artificial eye. So we get a desired effect. Dynamic orbital implants are those which expand with the growth of the orbit. They are either biological in the form of dermis spark graft, or one can use a balloon expander, or readily tissue expanders are available. Dermis spark graft has its donor site morbidity issue, but it is excellent and most compatible graft, and it grows slowly. But more popular nowadays are expanders. They are called as hydrogel expanders. They can be placed in the cul-de-sac when they are dehydrated. They are small, and when they get hydrated, they generally get hydrated very slowly. They expand, and they subsequently expand the size of the cul-de-sac, and they can be used into the orbit in the form of pallets through the small incision. So coming to the complex anophthalmos, which I told you, a second type where there is a anophthalmos associated with a eyelid abnormality. Like in this case, there is a pseudocoloboma, there is a coloboma, and there is a microblepharon. So we have to, in such case, we have to start early. We have to first repair the lid, whatever mean you have to repair. Once you get a good amount of tissue if in the upper lid and lower lid, then you can start the stretching as usual. Yeah, always parents always are unhappy, and you are always on the happier side. So once we have a lid, then we can stretch it with a conformer. Like in this case, I use a silicone implant, which we divided into or fashion into a different sizes, and the conformer implant, and then larger conformer. So subsequently, we get some amount of lid tissue in the upper lid and lower lid. Then also the parents were never happy because they don't see the artificial eye in place. So we have to build an conjunctival sac in such case, and fornix formation was subsequently done, and implant was put, and at the last, from 1 year to 1.5 years, we
1 minute left, sir.
We get some amount of upper lid and lower lid, and sufficient amount of cul-de-sac with orbital support, and there is a marked improvement in the facial features also. So counseling is very much important part, because apart from doctor, parents had to participate actively in the management of case. They have to understand the burden of multiple surgery and prolonged recovery, and they should know the realistic expectation. So to conclude, building the Taj Mahal begins in 1932. It completed around 8 years, 6 to 8 years, but it formed a miracle. The miracle is always built by brick and brick. So you have to be patient. But it's never an end. It's always only a beginning for a new life for a child when you intervene properly. Thank you.
Dr. Rachna, if you could invite the next speaker, Dr. Seema.
Right. Thank you, Milind. Thank you for that interesting
Thank you, ma'am.
talk. I now invite Professor Seema Kashyap. Ma'am, everyone knows ma'am. I think ma'am is a big name in ocular pathology, and I think no session is complete without touching upon pathology. So I invite ma'am to speak on interesting lacrimal lesions. Dr. Seema Kashyap.
Dr. Seema, we can see your screen. You can get started.
Yeah, hello everybody. Today I shall be talking on, I shall be showing 5 interesting lacrimal lesions. This was a 22-year-old male who had a painless progressive swelling below the medial canthus of the right eye since the last 12 years. Now, on imaging, conventional DCG showed this dilated lacrimal sac with filling defects. CT dacrocystography also showed similar results. Peroperatively, when the sac was opened, there were multiple polypoidal structures which were seen. The gross specimen, this is cut open here. Also, you can see the multiple polypoidal structures. And microscopy gave away the answer. This was very interesting. The subepithelium showed dense lymphoplasmacytic infiltrate along with these circular lesions in various stages of development. This is another high PAR. And as you go to the highest PAR, you can see that this is a sporangia filled with multiple spores. So this was a case of rhinosporidiosis. We don't need special stains, but histopathology itself is diagnostic. So this patient was put on tablet Dapsone and he responded very well. So this is basically a localized granulomatous disease of the mucous membrane, rarely seen in the lacrimal sac. Earlier, it used to be considered as a fungus, but now we know that this is actually an aquatic protestant parasite, Rhinosporidium seaberry, belonging to the class Mesomycetus. Next case, this is a 6-year-old male who presented with painless swelling in the left medial canthal region, and he had epiphora for 1 month. So outside, he was diagnosed as acute dacrocystitis. He was put on antibiotics, but he did not respond to treatment. Then he was referred to RPC. And when this patient came here, the CT showed a soft tissue mass at the medial canthus of the left orbit, and the underlying bone was normal. So a biopsy was done. The biopsy showed areas of hemorrhage, large areas of necrosis, and in between you could see these islands of tumor cells. Some present singly, as you can see over here, and high PAR, you can see these islands consisted of large tumor cells, prominent nucleoli, high NC ratio, abundant cytoplasm. At places there was squamous differentiation as well in this necrotic background. So this was reported as a poorly differentiated squamous cell carcinoma of the lacrimal sac. So the patient, after some time, the mass started increasing again, and a CT which was done showed a rapid increase in size of the mass. So the patient was put on neoadjuvant chemotherapy. And after that, you can see the post neoadjuvant chemotherapy, you can see marked reduction in the size of this mass. There was excellent response, but the patient again was lost to follow-up, and he then succumbed to his disease. So this was a rare case presenting in a 6-year-old child. Typically, lacrimal sac tumors present in the 5th decade, and diagnosis is often delayed in such cases because of the rarity and the way he presented as dacrocystitis. So always a high degree of suspicion and should be kept in such cases. Case number 3 was a 45-year-old male who presented with swelling in the supralateral aspect of the left upper lid for 1 month. CT showed an enhancing mass in the lacrimal gland, and clinically it was diagnosed as a pleomorphic adenoma or a pseudotumor. So this is the low PAR picture when we the microscopy. The microscopy on low PAR showed dense lymphoplasmacytic infiltrate, and here you can see on low PAR also there are these caught up lacrimal gland acini and large areas of fibrosis in the center. So these are the dense lymphoplasmacytic infiltrate, caught up lacrimal gland acini, and you can see these are all plasma cells. There were numerous plasma cells, and along with that, this picture shows large areas of fibrosis. So we kept the possibility of IgG4 in this particular case, and IgG was strongly positive, and IgG4 also was strongly positive. So this was diagnosed as an IgG4 related disease. Lacrimal gland is most commonly involved site in this particular thing in the ocular region. And these patients should be kept on regular follow-up or close follow-up, since they may have an increased risk of non-Hodgkin's lymphoma. Now, histopathologically, there are three major histopath features, which I just showed you, which was there in our case as dense lymphoplasmacytic infiltrate, large areas of fibrosis, and obliterative phlebitis. And eosinophils is also one of the minor criteria. So we fulfilled all these criteria, and IgG4 positive plasma cells should be more than 10 per HiPAR field. That's a cutoff value. We had much more than that, and the ratio was also more than 40. So this is a new entity, an inflammatory condition, which should be kept in mind. This was a 55-year-old male who had swelling in the left eye for 2 years and diminution of vision for 2 months. So this was a gross specimen which was sent, and you can see the cut surface, which has an heterogeneous appearance. And microscopic examination showed these high-grade tumor. You have this islands of tumor cells arranged in the form of acini, pods, duct-like structures. And HiPAR shows you have these large tumor cells with high NC ratio, prominent nucleoli. You have these mitotic figures, prominent nucleoli, abundant eosinophilic cytoplasm, and also comido pattern, that is necrosis in the center of the island, which resembles a breast duct carcinoma. So this is a high aggressive tumor which showed perineural invasion in this particular case, and vascular invasion was also seen in this particular case. So this was an aggressive, high-grade aggressive lacrimal duct carcinoma, which is similar to ductal carcinoma of the breast. Majority of these occur in the major salivary glands. It's rare in the minor salivary glands. And my last case is
1 minute remaining, ma'am.
Yeah, I'll just finish up. A 44-year-old male who presented with right eye proptosis for 2 to 3 years associated with pain. And in 2012, he had an orbitotomy done outside. The details were not available. And CT showed a supralateral mass in residual mass in the orbit in the lacrimal fossa region. So here you can see in the microscopic section, there are two different areas. This is one area and this is another different looking area. And if you see on the HiPAR, this is a pleomorphic adenoma. You can see these benign epithelial islands in the fibromyxoid stroma. So this was the pleomorphic adenoma area, and this is the aggressive looking tumor. Here you can see on the HiPAR, these are gland-like structures with hyperchromatic nuclei. There's a lot of pleomorphism. CK was positive. So this was a case of carcinoma, pleomorphic adenoma, as it is known as, and which results from accumulation of genetic instabilities in long-standing cases. These are extremely aggressive tumors, and 25 to 50% of them develop recurrences. So these should be followed up carefully. Thank you.
Can I request the moderator, Dr. Rachna, to unmute herself, please? We have our next speaker, Dr. Debraj. Could you please start your screen sharing in the meanwhile? Dr. Rachna, you could invite the next speaker.
Thank you for guiding.
Sorry, ma'am. I'm just trying to keep it on time. It's a very difficult task.
The class is also around, but that's okay. So yeah, I'd like to invite Dr. Debraj Shom, and he is very well known for his work in aesthetic surgery in and around the eye. So and it's always interesting to hear his talks. He has some interesting tips for the facial rejuvenation. So I welcome Dr. Debraj Shom for his talk. It is Tactics for Under Eye Rejuvenation Work.
Thank you, ma'am. Thank you very much. Thank you to DOS for having me here, and thank you to all my teachers and friends to be a part of this august faculty. My name is Debraj Shom, and I practice in Mumbai, mainly in Mumbai. And some financial disclosures are in place. Currently, I am a trainer and a key opinion leader for Allergan and Merz, and these are the products which have been used in this presentation. And I've been a trainer for the past 15 years. And acknowledgement to the other consultants of the aesthetic clinics team is very important, especially our dermatology team, which makes us look better surgeons than we actually are. Now, the eyes say it all, especially when you look at this aging Bollywood superstar. You can tell very clearly that as time goes on, the rest of the face looks more or less similar, but the eyes tell it all. We understand that the reason that the eyes tell it all, because the eye actually, the under eye skin is the thinnest skin of the human body. And we understand that because of all the blinking which this part of the skin undergoes, there's a lot of aging changes which tend to occur. Now, the OG curve is something that we know very well. We are very clear that it's a S-shaped curve, which is seen especially when you look at a beautiful woman at 45 degrees. And essentially, the symmetry of the eyes really determines the beauty of the face. So, in fact, if you were paying close attention to this particular photograph, you notice a beautiful lady. In fact, if you've been looking very closely as I was at her eyes, you've missed the fact that her lips are actually asymmetrical. The left side of the lip is actually far asymmetrical compared to the right side of the lips. It's a very poorly done filler job, but you weren't even noticing it because you were drawn to the eyes. And that's where I think oculofacial plastic surgeons make a mark in the field of aesthetics, because it all starts with the eyes socially. Now, facial aging, whatever it really means, basically all the tissues of the face moving downwards and medially, because mother gravity, ever so kind, bring us all down all the time. And so as a result of which you have the under eye hollows which are developing, as well as you have the nasolabial folds which are developing. And in fact, if aging is the movement of the tissues downwards and medially, anti-aging would basically be movement of the tissues upwards and laterally. And if you sort of understood that basic concept, then anti-aging therapy of any kind becomes easier. Now, as we've spoken about this, we know that the under eye area shows the earliest signs, and depending on whether you're a surgeon or a non-surgeon, you would basically think that fillers would solve all or blepharoplasty would solve all. I tend to disagree with both. I tend to believe that diagnosis and treatment actually requires a systematic diagnostic approach and individualized therapy for each of our patients. And therefore, the objective always has to be, can I treat this patient at the lowest possible cost with the lowest possible risk? And therefore, it becomes very, very important. Now, if you look at a patient like this, if I asked you, is this a medical case or a surgical case? And you said surgical, you'd be more or less correct. But there are patients whom we've actually treated, even in these kind of eye bags, medically. And I think it's important for us to have different, no one size fits all, and therefore having different tools in our armamentarium, make sure that our patients have access to greater amount of choices. And obviously, even if you did the surgery, the texture, the tone, and the quality of the skin may not be improved with surgery alone. So in general, this is a paper that we are writing up right now, where we are talking about the under eye, and we are talking about it in terms of topography, in terms of the troughs, the tunnels, the valleys, and the mountains. And that's a simple way to teach, a simple way also for people to figure out how exactly to treat. And that's what we mean by troughs, tunnels, valleys, and mountains. And if you think of the fact that these are like topography, this is like the landscape out there, it becomes easier to teach, and it also becomes easier to treat. Now, if you look at this particular patient, 27-year-old model coordinator, does not want to take risks, has these under eye tear trough deformities caused by the tear trough ligament. Frankly, there's nothing better than fillers. Low G prime filler, you keep the bevel of the needle down, you sort of inject it properly, and you get lovely results. Patient looks much younger, much happier, eyes shine more in due course of time. Or if you look at this 29-year-old, again, model coordinator in front of the high definition camera, doesn't look that great. And this particular patient also, you see how after injecting filler, the lid cheek junction actually reduces significantly. The lids look much more aesthetic and younger. Or if when patients are smiling, some of them end up having a situation where the hypertrophic orbicularis roll actually obliterates the way they look. And using botulinum toxin in some of these patients can remove this. This is a slide that I borrowed from my very close friend Milind Naik. And or if you have patients like these, this particular 28-year-old came in because she wanted to get ptosis surgery done. And she actually complained of the fact that one eye was different in shape compared to the other side. But you can see that MRD1 in both the eyes is almost the same. But when she smiles, you can see the left eye becomes much smaller. Also, when she's not smiling, there's an inferior scleral show on the right side, which is very marked. So treating these with surgery, I'm not sure whether we can really treat 0.5 millimeters of ptosis predictably in every patient. And therefore, instead of doing a surgery, do a little bit of Botox, so a couple of units of Botox, a little bit of filler, and you get this sort of a result. And now when she smiles, you can see the eyes look much more symmetrical. Yes, the botulinum toxin will need to be repeated every 3 months, but she's happy doing that. And she's been following up for the last 8 years. And the fillers are done once in every 18 months or so, and we avoided a surgery in her. Or this particular lady, again, asymmetry of the face, right side looks much smaller than the left, left eyelid bag looks larger. She's 34. Do you want to do her first bleph at age 34? Or do you want to do a filler? And if you choose to do a filler, then it's easy to sort of camouflage the mountain. Now, do you want to remove the mountain with surgery, or do you want to camouflage it with filler? That's a discussion that is for another day. But that's how the patient looks 7 days later, younger, rested, smaller lid crease junction, a lid cheek junction, and she looks great. The facial thread lift is something that we do very regularly. And these are non-surgical threads. These are done with Prilocaine, and you can basically put these threads in and cause the fat pads to be lifted up. It's a non-surgical facelift which takes 30 minutes and lasts for about 2 years or so. These are some of our workhorse lasers that we use, especially for under-eye dark circles, etc. And these are some of the patients with combination treatments who can get treated like this. Sorry, I'm having to rush, but just want to be in time. This is a very interesting paper that we have, and I recommend that everyone should read this. This is about botulinum toxin being used in scars, and I'll be happy to send a PDF to anyone who wants to read it. And these are some of the results which can be caused using botulinum toxins, lasers, and so on and so forth with scars. In summary, beautiful eyes is equal to a beautiful face, and it's important to have a wide armamentarium. As we move on in life, people want better and better results with lower and lower risk. And that's what having a combination of non-surgical and surgical techniques gives us. And thank you once again for your attention and a really, really patient hearing. Thank you.
Thank you, Dr. Debraj. That was really comprehensive, given that the time limitation was there, but your cases were very interesting, and thank you for joining us.
Thank you, Vikas.
Next, I would like to invite Dr. Jyoti Batra. Dr. Jyoti Batra is a consultant at Noida Eye Care. Is she there, Dr. Jyoti?
Yes, I'm there.
Okay. Dr. Jyoti would be talking to us about imaging modalities. Dr. Jyoti, please share your slides.
Am I not sharing my slide? Am I?
Yes, now they're visible. Yes, you can put in the slide share mode.
Yeah, just give me a second more. Does that become better? Is that there?
Yes, ma'am, you can get started.
Yeah, so it's rather an extensive topic, and we'll briefly touch on the imaging part. So we'll be looking at the basics, essentially more for a general ophthalmologist rather than for senior oculoplasty people that we have here on board. So I have no financial interest. There's one thing that I've always wanted, and I keep telling my students, that imaging should always be an aid or an help, and you should never treat a patient based on the imaging. So when you're ordering an imaging or asking for an imaging, there should be a clear plan that what you want from the imaging, what you want, the information that you want to extract or expect from an imaging to give you. It should help in diagnosis or prognosis, or should have medical legal importance. Otherwise, it holds no value. We'll be touching briefly upon X-ray, CT scan, which can be with or without contrast, iodinated contrast, MRI, which can be with the gadolinium contrast, and ultrasound with the Doppler. So X-ray is the most basic and investigation, and there is the lateral and the AP views depending upon how the imaging is taken. And there is the Waters view, which is more for sinuses. So X-ray, as we know, is a low cost modality, and it can, as a clinical use, I think is largely restricted to finding out whether there is a presence of an absence of an orbital foreign body in cases of trauma. Otherwise, as a clinical use, we don't end up using it so much. Coming to ultrasound, the basic technique is of a sound wave reflecting back, and you pick up the image which has been, the sound wave which has been picked up. And there's an A scan, as we know, and the B scan, as we know. And based on how we place it in relation to the globe, we have the longitudinal transfer and the axial scans. And there are different frequency. If we increase the frequency, we increase the resolution, but we reduce the depth to which we are able to explore. And there's another thing which is known as the gain or the volume. It's almost like a volume in an ultrasound. And if you increase the gain, it makes it more loud, and you can increase the sensitivity of picking up things. But if you want to look at it more closely as to what the thing is, reducing the gain might just give you more resolution. This is with a Doppler to see how the blood supply is. Now, the advantage of a specific advantage of an ultrasound over other imaging modality is its ability to show a solid versus fluid nature, which in the presence of a mass, even on a CT scan or an MRI, may not be able to yield you. For example, there is this, there was this a young man with the proptosis, and he had this mass in the lower orbit around the muscles, and it looked like a mass till we got an ultrasound done, which showed the cystic nature of the disease, and we could not have thought about it. Looked like either a little less dense, but the fluid nature is best picked up on an ultrasound. The disadvantage is that the depth is limited, it is user dependent, and it's a contact procedure. So if there's an open globe, etc., and there's a pressure that we can give, so we might want to not consider it. There is, depending upon how the lesion, it is hypoechoic or hypoechoic. Coming to CT scans, well, the CT scans is like an advanced X-ray kind of machine. It gathers all the information from various sections that have been given. It carries a lot of radiation. We sometimes tend to underestimate the amount of radiation which comes in with the scan of the head or the orbit. It's almost equivalent to 2 to 8 years of natural exposure that we get, radiation exposure that we get. So we should think twice before ordering a re-CT scan. We have something known as density, and the air is the lightest, -1000. It appears like the lightest, the darkest black. The water is gray. And depending upon how white, we have the Hounsfield value to tell us the density of the lesion. There's an iodinated contrast in CT scans. Now we're looking at clinical situations where we get imaging done. Commonly trauma, essentially for 2 things. One is to look for foreign bodies, and 2 is in cases of fractures, etc. So when we're looking at foreign bodies, the presence or absence, we can look at as X-ray to see whether there is a foreign body which is present or not. There are techniques for localizing on a scan whether it's intraocular, but those are far too cumbersome and not very practical. To localize, we end up using a CT scan, or if the lesion is too anterior or in the globe, we use a B scan. The CT scan can pick up a glass foreign body, which is otherwise transparent. What ends up getting missed is vegetative material. So you have a radiopaque foreign body, which can be seen on an X-ray, radiopaque body in the globe. But a vegetative foreign body can easily be missed on a scan, and these appear just as gray hollows. Fractures is the other situation in which we would want to look at scans. Get a CT scan done. The X-ray can sometimes suggest that a fracture is present, but the information that we need for treating it, we would need a CT scan, and we would want both the soft tissue and the bony window, which essentially means the area in the whole spectrum of -1000 to +1000, where your best details are shown up. For example, this is an X-ray which shows a fracture, but the details we need, the upper one is the bony window, where we're seeing the bony details, and the same fracture in soft tissue window where we're seeing the muscle details. So we would want both to be able to treat the patient further. The other common clinical situations where we would want an imaging is a suspected retinoblastoma. We would not want to entail such children to a radiation scan, to the radiation risk that CT brings in. So to establish a diagnosis, it's best to do a B scan. If you see small specks of calcification, that should be sufficient. We do not need a CT scan to look a confirmed calcification. The other step part where we want to evaluate the extent of disease, it's best to get an MRI done, but because of the cost and because of the general anesthesia requirement, we end up getting a CT scan done, but generally best to avoid CT scans in such children. So we have got this retinoblastoma with areas of calcification within it, and a melanoma, also an intraocular mass where the B scan is quite characteristic. The other common clinical situation is patients with proptosis who come to us. The most common cause of proptosis, as we know, is thyroid eye disease. Now, a lot of patients who are sent across with thyroid eye, the first thing which is done for a patient with proptosis is often an imaging. And I believe that a lot of classic thyroid eye disease patients who have hyperthyroidism, bilateral, almost symmetrical lid retraction proptosis, a lot of them do not need any sort of an imaging to be treated. And once you clear on the diagnosis that this is a thyroid eye disease, they can be treated just for the disease, and just the tendon sparing thickening doesn't have to be established to take them further in treatment. We would want a scan done if there is a significant asymmetry when you're
1 minute
other
remaining, ma'am.
differences, or when you're planning for a pre-op decompression or a dysthyroid optic neuropathy. For example, this is a classic tendon sparing muscle thickening, which is being seen. And we just want to quickly see as to how to look at a scan. So first, you want to see whether it's a CT or an MRI. You look at the bone. If it's white, it's a CT. If it's black, it's an MRI. Then depending upon where the section is taken, axial cuts will look like this. Coronals are front to back. Sagittals are sideways. And then this is the soft tissue and the bony, where what you're seeing better. A normal CT scan, right at the top, this is the SRLPS complex. This is the globe, the optic nerve, the muscles. And again, the optic nerve is seen behind, surrounded by the recti. And quickly at the MRI, and MRI is frankly more complex. There is a T1 and the T2. With the T1, the fat appears brighter, and the T2, and there are the static separation images where if you want a contrast in the orbit, it actually acts like a automatic contrast. So this is the normal T1, T2. I think it will be too complex to dwell into the details right now. And I think I lost my screen, so I think that's
Dr. Rachna, could you please unmute yourself as well? Dr. Vikas, over to you.
Yeah, thank you, Dr. Jyoti. Excellent talk. Again, the limitation of time is the villain. Anyhow, we have to hand over the session to the next speaker. So we have one speaker left in the end, that is Dr. Mridula Mehta, who is a prolific surgeon and a practitioner at Delhi. She will be talking about transconjunctival blepharoplasty. Ma'am, over to you.
Hi, everybody. So I'll start sharing my screen. Is my screen visible?
Not yet, ma'am. Could you please try again?
Share screen.
First, for open your PPT, go to Zoom. Please click on share screen button, green color on your Zoom.
I'm trying, but it's not coming. Select.
Is my working? Please put on slideshow, ma'am. Click on slideshow.
So is my screen visible?
Yes, ma'am. Please go ahead.
Okay. So hello, everybody. Regards to my seniors. So 1 second. So I'll be talking about transconjunctival blepharoplasty. It's very fascinating that we approach the orbital fat without any skin incision. And usually these approaches, they don't require stitch also. Basically, transconjunctival blepharoplasty is done for cosmetic improvement of lower lids. However, there are times when some degree of skin and tendon manipulation will be necessary during this transconjunctival blepharoplasty. Now, basic goals of eyelid rejuvenation are: patient wants the restoration of youthful contours, minimal complications, and as a surgeon, we want to maintain the lid position. Surgical approaches for eyelids are basically transcutaneous and transconjunctival, but subciliary transcutaneous blepharoplasty has been associated with lower eyelid retraction rates up to 20%, which is less with transconjunctival. This is one case that came to me. It is a complication of transcutaneous blepharoplasty. You can very well see the lower lid malposition, ectropion, the canthal dystopia, the skin discoloration. So to avoid these and to avoid trauma to orbital septum, we prefer transconjunctival approach. Basically, transconjunctival blepharoplasty can be purely done to remove just the fat, or it can be done in association with lateral canthopexy or canthoplasty to tighten the lateral canthal tendon. Sometimes we do it with a pinch of skin excision to again tackle the skin. Also, transconjunctival blepharoplasty can be done with release of orbitomalar ligament and fat transposition, along with the grafting, fat grafting, lateral canthal tightening. So it is can be combined or can be done alone, depending upon the kind of case you have and the requirements. Other adjuvant procedures which can often be done with transconjunctival blepharoplasty are chemical peels, CO2 laser resurfacing, light therapy, because patient may want improvement in irregularities, wrinkles, lesions, etc. Now, relevant anatomy is normal lid position is normally the lower eyelid. It lies at the limbus or just above the limbus, but as we age, it comes little down. The medial and the lateral canthal tendons, they become lax. The skin changes, it becomes more thin. Actinic damage is there, atrophic. The septum becomes weak. There is bulging of the fat. So for any good contour, we need tight canthal tendons, good orbicularis oculi tone, normal tarsal plate, and normal skin. Another little bit of relevant anatomy is the fat pads, which we will be dealing during the transconjunctival approach, or even with the skin approach. The medial, in the lower lid, we have the medial fat pad, the central, and the temporal lateral. And we have to always think about, remember, there is an inferior oblique that is hidden in between these fat pads, which we have to avoid damage to. It's very important to evaluate your patient completely. Detailed medical history is very important. I must say, patient is on blood thinner, hypertensive, diabetic, anxious type. So you have to really, a COPD patients, patients on sleep, patient with sleep apnea. These are the patients which will likely to have some kind of complications most of it. Complete ophthalmic examination, skin examination, previous cosmetic procedures. You have to talk in detail to patient, ask to listen to what he or she wants and how you can benefit. It's basically the procedure and patient selection is surgeon's responsibility, and for that complete detailed history is very important. General ocular examination is also must. Upper lid examination I'm skipping because transconjunctival mainly deals with the lower lid. Lower lid, you have to see the skin, the fat, lid retraction, the pinch test, the distraction test, the canthal positions. You have to document photographically in primary, up gaze, and down gaze. Now, anesthesia, usually we do under local anesthesia, and topically we give paracaine eye drops. But preferably, you should have an anesthetist around who will sedate the patient a little bit so that the patient's anxiety level is controlled. Now, transconjunctival, usually the incision is given few millimeters below the lower border of the tarsus. You do blunt dissection and expose the fat, clamp, and then cauterize. I'll show the video in the end. It's a little clip. Here you can see how we clamp and just cauterize it. Because we need perfect hemostasis at the end. During the surgery also we can use cold compresses, cold saline, almost frozen saline, so that there is less bleeding. We can combine the surgery. This surgery I did this last week only, and with the mini lateral eyelid lift. We have done transconjunctival fat removal, plus now at the lateral canthal, we give a lateral canthal incision, straight incision, and then dissect and identify the SMAS layer, and then we can, with a non-absorbable suture, hitch it with the periosteum. Postoperatively, oral antibiotics, analgesics, topical antibiotics, lubricants are important. Cold compress, you have to tell patient that they have to do frequently cold compress so that there is no hematoma, endless swelling, head elevation. Patient has to come back for the follow-up, visual acuity monitoring, restrict physical activity, no heavy work, no weight lifting. at least for 1 week or so. These are some of the photographs. This is one case. This is the pre-op photograph. You can see the eyelid tone is normal. The lower lid position is normal. In the up gaze, down gaze. This can help assess the fat better. This is immediately after surgery on table. This is the first post-operative. We do not patch patients usually. You can appreciate that there is minimal hemorrhage, little edema, but acceptable. This is 4 months after the surgery. This is a little residual fat pad. So the patient wanted resurgery. So resurgery was done after 4 months. And this is first day post-op, and this is again a follow-up. This is the even after 2 surgeries, there is not much scar, not much congestion. This is after 4 months follow-up of the left eye surgery. This is second surgery, first day follow-up. Now complications which can happen are chemosis, infection, bleeding, residual prominence of fat parts. Problem is when the patient is lying down due to gravity, if there is minimal fat, it will fall back. And means preferably, I do not tug up the fat pads a lot. Whatever comes out easily, we do that. Tugging will cause traction on the optic nerve. So that is why I think this residual fat pads happen. Lower lid retraction can happen because after surgery, whatever the scar will form, the lower lid, between lower lid retractors, orbital septum, the skin, it will pull the lower lid down and change the contour of the lower lid. Excess fat removal can happen, and that can lead to hollow eyelids, trauma to inferior oblique, double vision, loss of vision. These are very seldom that happen. More is hematoma and all. Thank you for your attention, and if I have time, I'll try to share my video also.
Madam, we are behind time, running behind schedule. Yeah.
I'll just show a 30 seconds clip.
Ma'am, we are already running delayed, and we have to hand over the hall to the next session, ma'am.
Okay, just
If you could, maybe if you could conclude with your words, I mean, that would be helpful if that's okay with the chairpersons as well.
Yeah, thank you for your kind attention. This is how we cauterize and clamp and cauterize the fat, and these are the final results. Thank you so much.
Thank you so much. With respect to all the moderators, all the speakers, on behalf of the organizing committee, I would like to thank the chairperson, the co-chairperson, the conveners, the co-conveners, and the moderators for finishing this session. With respect to time, I would like to move to the next session. Thank you so much. Can I request our chairperson, Dr. A.K. Grover, sir, to please switch on the camera and also unmute himself. We also have the co-chairperson, Dr. Santosh Honavar. We've got the convener, Dr. Anita Sethi. We've got the co-convener, Dr. Mukesh Sharma. We've got the moderator, Dr. Gunjan Saluja. We've got the panelist, Dr. Milind Nayak, Dr. Urmil Chawla, and Dr. Nivet Lomi. I request all of them to please unmute themselves and switch on the camera. In the meanwhile, I also request our first speaker, Dr. Milind Nayak, who's present with us, to please start his screen sharing. Over to the moderators.
Good evening, everyone. Welcome to this session 2, which is a continuation of this session that we've just had, oculoplasty and oncology, and we have some very exciting subjects under discussion covering both the oculoplastics as well as lacrimal surgery. We also have aesthetics, and we also have oncology covered in this session. And we have some of the brightest stars on the oculoplastic horizon in this session, including Dr. Santosh, Dr. Milind, Dr. Mukesh, Dr. Anita, and so on. And we will look forward to some exciting talks. And no better way to begin than with Milind Nayak, a real star on oculoplastics scenario, and he talks to us for the general ophthalmologist. He highlights what is important in oculoplastics. Dr. Milind.
Very good evening. Thank you, chairpersons, and DOS as well as Namrata for this wonderful opportunity. It has always been a physical meeting, but nevertheless, this is as vibrant as ever. Are my slides visible?
Yes, sir. Yes, they are.
Okay, great. So focus is going to be on the general ophthalmologist and something that each of us sees in our clinic once in a while. And almost always oculoplasty is looked down upon many times because the first thing the ophthalmologist gets exposed to plasty is a resident watching DCR, where you see nothing but blood. But if you look at it, the field is very exciting, and here are some interesting statistics for everyone who's a general ophthalmologist as to whether you should get into this interesting field. So cataracts per patient are only 2, but there are 4 eyelids and there are multiple wrinkles. So naturally, the space that you have in this field and this area is much more. Obviously, once you get rid of the glasses, there are a lot more periocular issues to be treated. We had some wonderful talks in the previous session. So the question is, should you be doing plasty as being a general ophthalmologist? The answer is absolutely yes. And what is the scope? I'm just going to quickly touch upon a few aspects which are very common in our day-to-day practice as a general ophthalmologist. Starting with the implant, you all are very well aware of this one, but there is another one which is associated with an enucleation or an evisceration surgery. Just to highlight a lady without an implant on the right side, you can see the prosthesis, its sunken appearance, and here is the same lady after a secondary implant. So if this previous surgery was accompanied by an implant as a primary setting, we wouldn't have required this surgery. So always place an implant when possible in order to build the volume that is lost in the socket. Talking about nodules, this is a no-brainer for any ophthalmologist. This is obviously a chalazion with a red posterior surface. But compare that to this particular man where the lesion is pretty much punched out, well defined. The border between normal and abnormal is very abrupt, and even the posterior surface looks quite clean. So this is more likely to be a cyst than a chalazion, and someone just trying to prick and incise and curate it is likely to face with a recurrence. So these kind of lesions particularly need either an anterior or a posterior approach surgery with complete removal of the cyst. Similarly, tags, nevi around the skin area, these are in the purview of dermatology, but periocular area, they usually do not venture. So these are simple surgeries for any general ophthalmologist to perform in the clinic. They don't need a sterile room, they just need a sterile environment. Here is an example of a marginal nevus excised, just a shave biopsy giving a better result, and couple of periocular skin tags pre and post surgery. I've spoken about this in several seminars, but here is an example of a chalazion being treated with a steroid injection rather than doing a curettage. You can see the amount of reduction after one, and probably one more would completely flatten it. It's a good alternative rather than performing a surgical intervention. The other prick that I want to talk about is botulinum toxin, which can be used very commonly in the various forms of facial spasms, which often present to the ophthalmologist. Here is a case of a classic myokemia, only a particular fascicle of the muscle is involved. And there are examples of benign essential blepharospasm, which is functionally blinding, as well as hemifacial spasm, where one half of the face is involved, and these could be significant social embarrassment and considerations. So these cases can be treated with standard injection sites in the periocular region. When it is hemifacial spasm, a couple of spots in the lower face also make it symmetrical. Typically in the training, we were taught that abscesses should be drained with a cruciate incision and with breakage of loculi with a spread of a forceps. We don't have that much of prime space available in the periocular region. So in this area, an abscess aspiration is a much better or less traumatic method, and we would soon be coming out with a paper in this regard. Talking about the flip, and this is particularly applied for patients who are just waiting for a cataract surgery. When you compare an entropion versus an ectropion, I would always worry more about the entropion because this is likely to harm the cornea, whereas the ectropion is usually harmless and maybe it's unsightly. So if your entropion is senile and the lashes are touching the cornea, it needs a surgical correction. Mild ectropion can always be ignored if epiphora is the only concern as soon as you confirm that the lacrimal apparatus is patent, whereas severe ectropion needs some form of correction prior to any intraocular surgery. Final point is about the flop or the drop. Here is a lady who had a right cataract. She underwent a very successful surgery, but look at what happened post-operation. There was a droopy eyelid or a post-cataract surgery ptosis. Now, it's easy to miss out on these things, particularly because cataract surgeons do not document with photographs, but it's important to identify early signs of a disinsertion. So if you look at this lady, if you look at the distance between the lashes and the lid fold, medially that distance or the tarsal show, what we call as, has increased. So she is already starting to develop a disinsertion medially. This patient, if she undergoes a peribulbar block or too much of stretching of the eyelid due to speculum, is likely to develop ptosis. So particularly in these cases, a warning could be given to the patient. So quick summary, we talked about the orbital implant, which should accompany every evisceration or enucleation, the know to differentiate chalazion from a cyst, small little tags around the eye can be surgically removed easily. We talked about Botox and how abscesses can be aspirated rather than drained extensively, and a little bit of ectropion, entropion, and ptosis around cataract surgery. And how to begin to get into this, maybe we'll save that for the next year's class. Thank you very much.
Thank you, Milind, for a really wonderful introduction. I almost want to start at the beginning again because that's really very inspiring, and I hope more of the audience have also got inspired to take up our chosen specialty. Would anybody like to ask any questions? Or maybe we can keep the questions sort of for the end. Dr. Mukesh, would you have any comment on this?
Well, very nice presentation and very good overview about the specialty as a whole. Because when I saw the topic which Dr. Milind was supposed to speak, I was wondering what he will narrate in such a short period of time, oculoplasty as a whole. But I think he did wonderfully well, and it's a very good overview about the specialty as a whole.
With respect to time, I request Dr. Anita ma'am to please move to the next speaker.
Okay. So we'll now invite Dr. A.K. Grover. He needs no introduction. He is going to now talk to us about neurofibromatosis. So over to you, sir.
Thank you, Anita. Good evening, everyone. Thank you, DOS, for this opportunity to participate in the annual program. I'm going to speak about the clinical presentation and management of the deformities caused by neurofibromatosis. As we know, we have the neurofibromatosis 1 and neurofibromatosis 2 as a part of the phacomatosis, probably the most common phacomatosis. Neurofibromatosis 2 presents largely with vestibular schwannomas and multiple central nervous system tumors, but it is the neurofibromatosis 1 or the Van Recklinghausen's disease which is of greater importance to the ophthalmologist. It's an autosomal dominant transmission, as we know with all other phacomatosis, and it is 1 in 3,000 live births. It has a multi-system involvement, as we know, and the expressivity of it varies. It may be mild, it may be severe, it may present with café au lait spots, cutaneous neurofibromas in most of the cases, but some other features are rare. And these features present at different stages or different ages. Some of the features start from the first year, but some like neurofibromatosis and some like malignancies and the pheochromocytomas occur only in later life. The plexiform neurofibromas, which concern us more, occur in about 1 to 22% in different series in cases of neurofibromatosis 1, and it is the progressive disfiguring caused by them which is of great importance to us. So when we evaluate these cases, we not only need to look in the periocular region, we need to do a systemic evaluation, and we need to do a good imaging. CT is a good choice because bony deformities are often present. I'm presenting the features observed by us in 19 patients. 18 of them were unilateral. This was the rare bilateral presentation with a predominant one eye involvement and a minimal second eye involvement. The clinical presentation in most cases is with diffuse eyelid thickening and hypertrophy of the eyelid in all patients. Sometimes the deformity may be very mild and may not require any management, but in others, the obscuration of visual axis may call for an early intervention in a child. Those with more severe deformities which involve the temporal region and face as well cause extensive deformities. And proptosis, displacement of the globe, are common involvements because of the orbital involvement as well. Temporal extension can be quite extensive. Associated bony defects are common. This is an example of a plexiform neurofibroma with multiple bony defects, including the diffuse enlargement of the orbit, as we can see here, or a dysplastic sphenoid bone leaving a gap through which the temporal lobe is coming into the orbital cavity. You may have a widened superior orbital fissure region, as you can see here, and an inward curve of the medial wall of the cavernous sinus. Surgery needs to be carried out earlier if it is occluding the visual axis in children, but in others, you may wait to carry out functional and aesthetic correction as indicated. Surgical management is difficult, and there are a number of surgical modalities described, but we'll look at one procedure which has served us best. For reconstruction of the abnormal eyelid, normal eyelid serves as a guide. We need to do both horizontal and vertical shortening, fixation of the lateral canthus, and correction of the ptosis. So this measurement of the normal horizontal and vertical dimensions on the normal side allows us to assess the amount of vertical and horizontal correction to be carried out, and use of a template from the normal eyelid superimposed on the involved side helps us in making these decisions of vertical and horizontal shortening. So this is the vertical shortening. This is the horizontal shortening carried out, and a lateral canthus reconstruction by attachment of tarsal plate to the inner periosteum of the lateral orbital rim by a permanent suture like Prolene is quite helpful. As you can see, we've done a vertical debulking and a horizontal shortening and re-anchored the lateral canthus here. Ptosis correction may be done as a primary procedure, but often secondary is the better choice because a better assessment can be done. A lid fold creation is ultimately carried out, and this gives a very good improvement in many cases. So those with brow, cheek, or temporal region, in spite of the difficulties involved, need to be debulked and gives quite satisfactory results. We'll be skipping the video. We'll look at some of the results. We're able to cause a significant debulking and open the palpebral fissure in most cases. Let's look at another example where we've done a vertical as well as the horizontal debulking, and we are able to get appearance which is significantly improved and the bulk significantly taken care of. Another example of a preoperative surgical debulking, correction of ptosis. The complications include incomplete excisions, which are only to be to be expected because it is a diffuse disease. Residual disease or residual ptosis is also common, and that is why a secondary procedure may often be the best choice. Contour needs to be carefully calibrated in these patients, and get a conjunctival exposure if you have not anchored your canthus well, and recurrences can occur particularly when they are operated at an earlier age. So an example of a conjunctival exposure and undercorrection can be seen here. To conclude, you can achieve gratifying results even in this difficult condition, but difficulties like incomplete excision, recurrences, and repeat interventions are only to be expected. However, a surgical removal must still be attempted to give a good functional and aesthetic restoration, which is important for the satisfaction and visual rehabilitation of the patient. Thank you.
Thank you, Dr. Grover, for a very good coverage of a very difficult subject. We are all getting these kind of difficult cases. And I actually take the help of the plastic surgeons because often the forehead and the nose is also involved. Just to save time, we'll keep questions for the end, discussion for the end, and now invite Dr. Mukesh. Dr. Mukesh is going to give a talk on his management scheme of blepharophimosis syndrome.
Good morning, good evening, everyone. It's at the outset, I'm thankful to DOS for giving me this opportunity. Today, I shall be discussing about blepharophimosis syndrome. We all know blepharophimosis syndrome is a difficult condition to treat. There are certain guidelines for this. So I'll be telling you about the way I follow these cases. Blepharophimosis syndrome, just a sec. Yeah, also known as Cohn-Romano syndrome, is a tetrad of severe bilateral ptosis, phimosis, or narrowing of horizontal palpebral fissure, telecanthus and epicanthus inversus, and then there may be other minor features also. It's a hereditary condition, autosomal dominant with the variable penetrance. We have treated, I think, around 6 families of blepharophimosis syndrome till date. These are 2 of the families which we have treated. So how to approach this particular condition? This should be done ideally in 2 stages. In first stage, we do medial canthoplasty along with lateral canthoplasty. And in second stage, frontalis sling is done for ptosis. There is no other option but to do frontalis sling. Sometimes these 2 stages are done in same sitting. There are people like Dr. Kasturi who are fond of doing this complete therapy in one sitting, but I don't like doing them in one sitting because what I feel is that if we do or if we try to achieve horizontal stretching along with vertical stretching in one go, then results are suboptimal. So in first stage, we try to achieve the horizontal stretching. We do medial and lateral canthoplasty, and in stage 2, typically after 2 months or so, we do the vertical stretching, that is ptosis correction. Now, how to do medial canthoplasty? There are various methods. One is Verwees YV plasty. Here, this Y is converted into V and excessive skin here is resected. But problem with this particular procedure is you get a point pull. This pull is not uniform, it's just at the point. So I don't like this particular procedure. Then one can do Mustardi's double jet plasty also. Here, these flaps are made and then they are transposed. But problem is that in this tiny area, there are too many flaps. So multiple scar lines are there and they are quite prominent, at least for initial few years. Then there is another procedure which is known as CU plasty. Here a C is converted into U and you resect the skin and muscle intervening. So this is my procedure of choice because what I feel is that here you get a uniform pull. It's not a point pull like our Verwees YV plasty. And also the scar line is also not very prominent. It gets hidden in the natural scar line of Langer's. So we have done till now around, till last year, around 58 cases. And we have always done it in 2 stages. Stage 1, generally at 4 to 5 years of age. This is one condition where parents, they always want you to contemplate surgery early. But problem is that if you do these medial and lateral canthoplasty earlier than 4 years or 3 years of age, then the results are not at all good, because the tissue is very lax, tissue is very elastic. So there is no rigidity and you do not get good correction at all. So ideally, it should always be done after 4 years of age. If there is very severe ptosis, then to avoid amblyopia, one can do temporary silicone sling. So as stage 1, we do CU-plasty plus shortening of MPL. Sometime in very severe cases, we also do transnasal wiring. This is combined with lateral canthoplasty. In stage 2, I always do fasciolata, because I feel in this particular condition where lids are very tight, fasciolata is hugely superior than silicone rod or any other artificial mat. Then lateral canthoplasty, sometime I repeat it along with fasciolata sling also, because you need to have lax upper lid for good correction. But if you repeat it in all cases, then sometime you got a flare of lateral canthus also. So should not be repeated in all cases. Wherever it is required, you can repeat it. This is one of our cases. She is awake and trying to look in primary gaze with the full effort of her frontalis. You can see eyebrows are arched up, but still she is not able to see because of the amount of ptosis she is having. So in this particular case, we did CU-plasty as first stage. And we have done a shortening of MPL with transnasal wiring. You can see here 26 gauge steel wire was used. And this was the correction on table. You get very good depth of medial canthus if you do transnasal wiring, but if you do not do it, then the depth of medial canthus is not there. It is a little superficial. So this is post-operative after 2 years of age. A reasonably good condition, good result in this particular condition. Yet another patient, appearance after first stage and second stage, and another one. So by employing these regime, we can achieve good correction in most of the cases, although the results are far from optimum. Like you do not get results as you get in severe ptosis, but this is a difficult condition we must understand, and we must inform it also to the patient that you will not be 100% normal. You will have to be realistic in your expectations. So yet another condition. See, this is the lateral flare of lateral canthus, which I was talking about, because we had done lateral canthoplasty twice. And you do just to have lax upper lid to achieve good ptosis correction, but you do get sometimes these kind of flares. So one must be careful while doing lateral canthoplasty. So yet another case. I think I'll be avoiding these videos. So to conclude, I believe a reasonably favorable outcome.
1 minute left, sir.
Yeah. Can be achieved by our 2-stage simple protocol. In that, in stage 1, we do CU-plasty along with shortening of MPL and transnasal wiring not in all cases, and also lateral canthoplasty. Stage 2, typically after more than 2 months, I always do fasciolata sling, though silicone rod also may be performed. I always perform it in pentagon manner. Canthoplasty, sometime I repeat, not always. If you repeat, it provides you good horizontal laxity for ptosis correction, but too much of this will give you lateral flare. So in the end, realistic results should always be explained to the patient and parents for your peace of mind. Thank you. Thank you for your patience.
Thank you, Dr. Mukesh, for an excellent demonstration of a difficult situation to handle, and you managed to be exactly in time. I will now invite Professor Urmil Chawla who is professor at Postgraduate Institute of Medical Sciences in Rohtak. She's going to share her experiences in probing in congenital NLDO, conventional versus endoscopic. Dr. Urmil.
Good evening, everybody. And at the outset, I would like to thank DOS for giving me this opportunity. And from the lids, we move to the lacrimal part. And my topic for today is probing in congenital NLDO, conventional versus endoscopic. So as we all know, the common etiology for the congenital nasolacrimal duct obstruction is the persistent membrane covering the nasolacrimal ostium at the valve of Hasner, which causes it. And the incidence is 1.2 to 30%. We often always see the triad of epiphora, discharge, and matting of eyelashes. And to evaluate clinically, the three basic things that we do is the Rho-Plus test, the tear meniscus height, and the fluorescent dye disappearance test. It can sometimes present as dacrocele also. So in this study by McEwen, he just told us about the spontaneous resolution that occurs in cases of CNLDO. And he found out that with the increasing of age, the percentage with which the spontaneous resolution occurs does decrease. So at 3 months of age, while it is 90%, at 6 months it becomes 75%, and at 9, 36%. Still, the overall rate of spontaneous resolution by the end of the first year of life has been reported to be 96%. Management, which is pretty good. Management of CNLDO is principally guided by natural history of the disease and high spontaneous remission rate by 1 year of age. And to augment this spontaneous resolution, we all know we have this Krigler's massage. The few basic important points which we all should know is tell the patient to press 10 times in one session, total 4 sessions in a day. This should be instructed to the residents, especially who just sometimes land up giving wrong instructions. Then the way to always press over the green area, avoid the yellow line or the bony edge to press. Do not move the finger over the nose or do not move the finger downward, and do not use the thumb. Now, how to decide when to move ahead with surgical intervention? The various questions which tell us are whether it is constant or intermittent, what is the frequency of symptom, age at which symptoms start, discharge, how it is, any significant birth history, history of photophobia, history of sinus surgery, aggravation due to cold, URI, or radiation treatment to nasal area. All these keeping in mind, we proceed further. Now, when and how? Improvement by age 12 months, it has been reported in 96% cases. And so if still the symptoms are persistent more than 9 to 12 months of age, then the intervention is planned. And the first line of intervention is probing and syringing, which results in good cure rate in the first sitting and 6% by repeated probing. Now, what few things which are debatable are, what is the time for initial probing, whether it should be early or late probing, whether it should be an office procedure or the OT, and whether it should be conventional or endoscopic. We all know it's a gold standard. We should remember the correct technique, going in the direction of the NLDO, BLD, which we say backward, laterally, and downward, the spring back test, the pop-up sound which we get once we pierce the membrane, and metal to metal touch for confirmation. Now, it can be done by a general ophthalmologist, a pediatric ophthalmologist, or an oculoplastic surgeon, and different results are found to be there. So, however, studies in experienced hand had been shown that it is successful in almost 70 to 97% of cases, with many reports around 90%. This I'm talking about the conventional probing. And the people who prefer the early probing, their argument is that why should they prolong the inflammation? It may result in secondary fibrosis, and it may reduce the chances of success also. And those who favor late, they argue that generally it's the results are spontaneous resolution are good by 1 year of age, then so why not to unnecessarily avoid it, and it can lead to iatrogenic stenosis. OT procedure should generally always be preferable, or office procedure only if there is really some problem with the PSC. The success rate has also been found to be more in the OT, and it is the recommended procedure. Now our main debate is whether it should be conventional or the endoscopic. Now conventional, we know the instrumentation we need, basically syringe, the probe like punctum dilator. While for endoscopic probing, we need a full set of instruments. Before we debate on the issue, let's go into the review of literature 1 minute. The mean age at presentation for a simple CNLDO has been found to be 17.6 months, while it has been found in complex cases to be 45.6 months. And the most common causes are bony obstruction and craniofacial syndromes and Barrett probe. And anatomical success and functional success with conventional CNL probing have been noted to be 97 and 94 in simple, and 58 and 51% in the complex cases. Also, comparing the whether if it is membranous, definitely we have more success rate compared to the bony bony. Buried probe variant was found to be 8%. So the incidence is less and late presentation. Success rate with conventional is still 88% in that also. So various studies in literature have concluded that conventional NL probing under GA is a safe and viable option as a primary treatment modality. And also in most cases, endoscopy is not required. However, the success rate comparable to with simple probing has been found in various studies ranging 91 to 86, and with endoscopic it definitely increases by 94, but not very significant. The major limitations, as we know, are availability, cost, and experience of surgeon, additional availability of equipment and instruments, extra steps of surgery, surgical time is increased. Cost range is definitely more. A normal to a high-tech endoscope ranges from 2 lakhs to 12 lakhs, and so it automatically increases the price. The most important need of an otolaryngologist specializing in endoscopic sinus surgery often to deal with the learning curve, and it can be difficult for inexperienced surgeons, and thorough knowledge is needed and high level of skill is again needed. And lastly, while this pandemic is still going on to some extent, we have to be careful about the endoscopic procedures still, since nasal tissues harbor high viral load, higher risk of surgeon, and effective disinfection of telescope is an dilemma, and obviously the endoscope part. So as we are always debating the choices between an Android and Apple, and knowing all the pros and cons, majority are still going for the Android. So we see that for the take-home message is, for at least till 18 months of age, conventional probing is definitely giving good results. Yes, for around ages more than 4 years, 6 years, there we can think of endoscopic probing under guided hands and if possible. So thank you so much. Thanks a lot.
Thank you, Dr. Burmil. That was a very nice, balanced presentation, presenting the pros and cons of early intervention, late intervention, endoscopic probing or otherwise. I think what you rightly emphasized, that the endoscopic method is useful for the older subjects. It is also important for those who are having a reprobing, those who have had a failed primary probing. I think that's one more area where we would almost always prefer to have an endoscopic visualization as well, either to carry out an inferior turbinate infecture, or as we often find, you have intramucosal opening of the probe and you often need to open it to carry out the procedure. Sometimes in the cases with a cystic presentation at early stage, you also have a nasal cyst and you need to take care of that. So there are several reasons and many of the other complex situations where you would need. We'll go on to the next talk now, which is the one by Dr. Kunjit Saluja on managing canalicular obstructions.
A very good evening, sir. Actually, the thing, there's some problem in sharing my screen. It is showing share content and it's not showing share screen. So I think we can move on to the next speaker. Meanwhile, I'll just sort this issue.
So admin, can you enable her screen sharing in the meanwhile while we request?
Could you just try again once, Dr. Gunjan?
Yeah, it's showing share photos, iCloud Drop and Dropbox.
Have you opened the PPT?
Yeah, my PPT is open, but again, I'm not able to share my screen.
Sometimes, ma'am, it happens due to technical difficulties. We are not able to proceed ahead. But since you recommended us moving to the next speaker, I would request Dr. Grover to move to the next speaker then.
So may we now have Dr. Anita Sethi, a prolific and a wonderful oculoplastic surgeon, to give us her 10 pearls in ptosis surgery. Anita, please share your screen.
Yeah, thank you. I'm just finding the screen. Yep.
We can see your screen, ma'am. Just put it in the presentation mode and you can get started.
Yeah. So I'm grateful to DOS for giving me this opportunity, and good evening to all friends, colleagues, and seniors here. So I'm going to share my top 10 pearls of ptosis surgery, just taking examples of some of the cases I've come across along the way. We all know that we must start at the beginning, and the pearl that I would like to highlight when we come to the beginning is our diagnosis, especially congenital versus acquired. There is an important part of the examination where in the down gaze, in the congenital ptosis, there will be increased palpebral aperture in the down gaze as compared to aponeurotic or acquired ptosis. And this is a very important point in deciding which surgery, how much of resection. So pearl number one is please make sure you reach the right diagnosis, what kind of a ptosis, and then amount of the ptosis as well. Point number two is, pearl number two is, how do we start the surgery? The surgery starts at your planning. We know our start point is the post-ptosis patient. Your end point is getting a good correction with a good contour. It should be symmetrical with a dynamic lid fold. And you have many routes to get there depending on the amount of ptosis, the procedure which you prefer. So you must plan it beforehand. There are cases where we've been called to the OT by our surgeon friends and told just operate, it's a ptosis patient. That is not something we should be doing. You must observe the patient, plan the surgery before you enter the OT. So pearl number three is related to LPS resection. I think identification of LPS is the single most important step in this surgery. The pad of fat is a really good landmark. So till you don't see the pad of fat, you have not found the LPS. The LPS will be below the pad of fat. And in early days, I know I have done a very good resection of the orbital septum and wondered why I haven't got any correction. So this is something we must all look out for. Please look out for the pad of fat. The LPS is going to only be below the pad of fat and nowhere else. The other important part is people want to know is how much should we resect? What is the correct amount of resection? And you must separate your LPS very carefully. And I feel that if you resect less than the Wittnau's ligament, you're not going to get any lift. And don't go by numbers. I mean, you can make your own nomogram, but most of us, by the feel of the LPS, you know how much to remove, and it is mostly approximate and not always in millimeters. So the next pearl is something I learned the hard way, is that you can have a congenital or a aponeurotic ptosis even in young children. And we had this patient whom I probably missed looking at the down gaze, treated her like congenital ptosis and got this terrible overcorrection, which I struggled with for weeks, and finally had to do a second procedure, lots of pulling down of the lid, and finally got a good result. So aponeurotic ptosis, again, be very, very careful. They can be in young, old, any age, and often we find there is a rolled up aponeurosis. It's just detached and rolled up. And you simply have to unroll it, and you may not even need to plicate it. You just unroll it and attach it, and you can get a very good correction. And there is a role for adjustable sutures in these aponeurotic ptosis. Pearl number 5 is for the acquired ptosis. Now, these are the most unpredictable, be it even traumatic, post-surgical, what we feel is a senile, and then, you do an LPS procedure and you go from being sleepy to shocked. So this is something we have to be very careful about, and you must have a backup plan. And I found if you explain to the patients that, look, yours is a little unpredictable, we may need to do a traction suture, we may need to do some massage, there may be a slight second procedure, it will take time to settle down. If you tell that to the patient and they kind of feel okay when you things kind of follow that kind of a picture. Now, the neurological ptosis is another difficult one. This was a patient of apraxia of lid opening with gaze paresis, and he really wanted to be able to see. He just couldn't see. So this is where the patient wanted the surgery more than the doctor. And we did a sling with undercorrection, and he was very happy. But you have to watch out for exposure. So the reversibility of the sling is something quite useful. And just to highlight, it is, even if it is 5, 7, 8, 10 years later, it comes out very easily. This is someone who put a band and it was protruding there. So we then took it out and then did a fascial lata. So the sling is reversible, can be used in places where you are not sure. Now the sling is very much maligned. I think it is the technique more than the material. So you have to get the correct depth and the correct plane, and make sure you bury the knot in a pocket. If you bury the knot or the sleeve in a pocket, it's not going to extrude. And I found tightening the knot horizontally gives me at least a much better lift, because it's not aided by gravity and it stays in position. Tips or pearls for facial lata, Dr. Mukesh has already shown us quite a bit. I would just like to say that wherever possible, do bilateral, because we are doing this for severe ptosis and we can't get symmetry if we do it unilaterally. I find the pentagon works better for me, and use thin strips of facial lata so that the knot isn't too big and bulky. I'm not going to go into the video, just this is the small incision. You can easily take out a big facial lata strip. The contour is also very important, and contour is because of the way you position your sutures and the way you tighten your sutures. So be very careful on that, because you need a good contour. And a dynamic lid fold which disappears on looking down and is prominent in looking in front and up. That is our aim of all the surgeries. So now the last pearl is that our surgery doesn't end when we put the last suture and we've done the patti. The post-operative care is extremely, extremely important, and it is definitely the surgeon's responsibility. We do know this young lady had 4 surgeries. I'd only done 1 of them before. This was her 4th surgery. So there's tremendous lid lag and lag of thalamus, and you can see there's an inverse bells over here, poor blink. So we have to follow her up and make sure that the cornea is well protected. And we can see in week 1, there was so much of lag of thalamus, but by the time we came to week 4, there is hardly any lag of thalamus or chances of exposure. So we need to follow them very, very carefully. So to summarize, my 10 pearls for surgery, really, you start the surgery when your ptosis patient walks into your office. You observe the patient, you try to understand what they want and counsel them well. And your surgery really ends when, after a month, your patient is confident enough to send you YouTube videos of her singing. So that's really when I think you can say the surgery has ended. Thank you.
Thank you, Anita, for that lovely presentation, which was very useful.
Sir, you're muted. Sir, you're muted.
Still muted. Okay. Thank you, Anita. Those are valuable pearls for everyone.
Thank you, Dr. Grover.
And we enjoyed having your pearls. We will now see if Dr. Urmil is ready. Can you share?
Yes, sir, I'm ready. And now I'll start my screen share. So a very good evening, everyone. Today I'll be dealing about the management of canalicular obstruction, the new ways ahead.
You're pretty not sure, ma'am.
Could you please just maybe go to the next slide, ma'am? It's coming totally white.
Okay, sure.
Please share right file, ma'am. Please stop sharing. Please share right file, ma'am. You're not sure PPT. Please share again, ma'am.
Yeah, I'll share again.
Please share right window, ma'am.
Yeah, now we can see it.
Thank you, Dr. Gunjan. It's working.
Start
with the first slide.
Yeah, it was just the introduction slide. A very good evening, everyone. I'm really very sorry for all these technical difficulties. So I'll be dealing today with the management of canalicular obstruction, the new ways ahead. Canalicular block can be classified as proximal, distal, or common canalicular block, depending upon the distance of the soft stop from the punctum. So if the soft stop is at 4 mm from the puncta, it is called to be the proximal canalicular block. And if it is at around 5 to 10 mm from the puncta, then it is said to be the distal canalicular block. And for the common canalicular block, it is at 10 mm from the puncta. So what are the common causes of canalicular block? They can either be congenital or acquired. Acquired causes can either be idiopathic, cicatrizing lesions. They can be neoplasms, post-traumatic, medications, or neoplasms. So what are the conventional modalities? As we know that the conventional modalities for the proximal canalicular obstruction chiefly includes conjunctival DCR with the placement of Peyer's Jones tube. And for the distal canalicular obstruction, one can either do a conjunctival DCR or a canalicular DCR. But are these conventional modalities safe, and are they the only ways to treat it? Because there are a large number of complications reported with the Jones tube, which include tube migration, obstruction, extrusion, infection, collection of secretions, tube blockage, diplopia, patient not being satisfied. They have a variable success rate, and also these surgeries do have a learning curve. So surgery may also not be the best option in children, elderly debilitated patients who are having multiple systemic illness. So in those situations, I would like to deal with some of the other non-invasive and simpler ways to treat them. One of them is lacrimal Botox for canalicular blocks. The rationale of using Botox for canalicular blocks is that the main and accessory lacrimal glands, they both significantly contribute to the reflex tear as well as the basal tear production. And giving botulinum toxin blocks the presynaptic release of acetylcholine, which is required for tear secretion. If you look, the botulinum toxin is injected in the lacrimal gland palpebral lobe. It is done under topical anesthesia after lifting the lateral upper lid manually to expose the palpebral lobe of the lacrimal gland, and patient is asked to look down in abduction. One can also use a Desmas retractor to expose the palpebral lobe. After that, 2.5 to 5 units of botulinum toxin is injected with the help of insulin syringe and a 30 gauge needle. Post-injection, artificial tears and antibiotic drops are prescribed to prevent the dry eyes. If you look at the literature, there have been various studies which have been done finding the role of botulinum toxin in the patients with proximal canalicular blocks as well as distal canalicular blocks. And they all had found that the Munk score had reduced from 4 to 1. The only disadvantage, if we look at, is the need for repeated injections. The injections usually need to be repeated at around 3 to 4 months. And second are the dry eyes. So it is important to monitor the Schirmer's test from time to time. But if you look at the advantages, it is technically easy, short duration, it's less invasive, safe, as well as reversible. Coming to the other non-invasive and a simpler way to treat the canalicular block is trephination. Mini-trephine is a 21 gauge stainless steel tube having an outer diameter of 0.81 mm and a length of 16 mm. It is provided with a plastic handle and hub. And you can see that we have a stellate here and an attachment for the syringe. So this is a surgical video which I would like to show for trephination. First of all, anesthesia is injected and then syringing and then probing is done first to find and reconfirm the level of the soft stop, as is being done in this case. In this case, the obstruction was found to be at around 10 mm from the puncta, and then we plan for the trephination. So this trephine is first being inserted through the puncta, and the stellate is removed. It is gradually then, with the help of screwing movements, inserted to the point where there was a soft stop, and all the adhesions are slowly, gently released with the screwing movements. Once you have cleared those obstructions, syringing is done to look for the patency of the system. And once you have confirmed with syringing that the system is patent, one can also try injecting mitomycin C 0.04% so as the readhesions are not formed. After that, after injection of mitomycin C, again a wash is given, and then following that, a stent is placed. You can insert, one can insert either a monocanalicular stent like Mini-Monoca stent or a bicanalicular stent depending upon the level of obstruction. So the limitations include stent extrusion, pyogenic granuloma, and false passage formation, and has a reported success rate of 52 to 92%. But it has an advantage that it's less invasive and a simple procedure. And even if it fails, we can always give a retrial for the same. Another interesting way which I came across was laser canaliculoplasty. Holmium laser, iridium YAG laser, ND YAG laser are some of the ways of treating this, and they have been described in opening the canalicular obstruction. The interesting part which I came across was the presence of an endoscopic and guided laser canaliculoplasty, where a Bowman's probe has been modified to deliver the laser as well as acting as an endoscope. But it has limitations, like there can be severe scarring after the procedure, which can further predispose to synovial closure and stenosis after the lacrimal stent removal. But nevertheless, it's a simple and safe procedure, and one is doing it under a direct visualization, which is preventing the complications like false passage formation. Coming to balloon canaliculoplasty. Balloon canaliculoplasty involves the introduction of a balloon catheter so as to atraumatic, it's an atraumatic procedure, and it aims to, under the fluoroscopic guidance, it aims to mechanically dilate and relieve the obstruction. Various studies have reported variable success rate. In a study by Ko et al., the success rate was 40% at a 2-year follow-up. And in the other study, at 6 months follow-up, 76.2% success rate was noted.
1 minute remaining, ma'am.
Yeah, it's my last slide only. So canalicular obstructions can be managed in a simpler way using the less invasive method. This is especially true in children, chronically ill debilitated patients, and in patients with multiple systemic illness. Although they might need to be repeated, but they are simple and done as a minor procedure. It saves time and also reduces the stress for the patient and the surgeon. Thank you.
Thank you, Gunjan. That was an excellent presentation. You are absolutely right. The trends have changed because of the availability of procedures like Botox and Sislet Refine. The numbers of conjunctivoplasty or Jones tube intubation have significantly come down. In fact, I would be doing about 1/10 of the Jones tube intubations that I was doing in the earlier years. And in my hands, the injections of Botox work for a period of about 6 months. And many of the patients, after about 2 or 3 injections, do not require any more injections. So it is a modality which has worked well. Dry eye is very rare. The only problem is ptosis. Sislet trephination is not very often useful in our conditions. Most of our blockages are due to chronic inflammations, and most of the times the culprit is a chronic meibomian gland disease. And there is a very diffuse canalicular and punctal stenosis in these cases, which usually doesn't do very well with Sislet trephination. And it is only an occasional case with a localized involvement in the mid or the distal canaliculus, which responds well to that. Thank you again. We'll go over to the next talk. Dr. Anita, would you please announce the next talk? Santosh is the next speaker, and it's great to have Santosh with us. Santosh has really made a huge difference to the world of oncology in this country and globally.
Thank you so much. I'll share my screen.
Yeah.
Just put it in the presentation mode. We can see it, sir.
See?
Yes, sir. You can go ahead, sir.
I thank viewers for the opportunity. I'll be speaking on adenoid cystic carcinoma of the lacrimal gland, current management strategies. It is the most common malignant epithelial tumor of the lacrimal gland, contributing to about 12 to 32% of epithelial tumors. Nevertheless, it is rare, contributing to only 2% of all orbital tumors. Let me show you a couple of cases and ask you what would you have done. This is a 28-year-old young male who has a very slowly evolving proptosis of the left eye with downward displacement. On imaging, he was found to have a lacrimal gland mass with bone destruction. Possibly you would have done excision of the mass and given radiation, or even done orbital exentration. What about this patient? A 10-year-old girl with subacute proptosis, looked like rhabdomyosarcoma or primitive neuroectodermal tumor, but incisional biopsy revealed a surprise that it was a basaloid variant of adenoid cystic carcinoma with immense amount of bone destruction already. Possibly you had to do orbitectomy with exentration and radiation. This would have been the standard of care 5, 7, 10 years ago. So adenoid cystic carcinoma of the lacrimal gland was conventionally managed with orbital exentration or local tumor excision with adjuvant external beam radiotherapy. Now, this adjuvant external beam radiotherapy was given by the radiation oncologist to the bed of the tumor, not necessarily an extended field radiation, and that is a new understanding. Consequently, adenoid cystic carcinoma of the lacrimal gland carried a grave prognosis. In fact, Henderson admitted that he feared adenoid cystic carcinoma of the lacrimal gland because he considered it the most evil of all primary neoplasia of the orbit. Obviously, it has a grave prognosis, recurrence is very high, metastasis is high, and mortality is extremely high over 5 to 15 years. Invariably, over the entire literature that has been published, that has been a similar experience. Intra-arterial neoadjuvant chemotherapy followed by orbital excitation showed us a ray of hope, but it was not as useful as it was thought to be. The question is, can we conserve yet improve life salvage? We bring in multimodal treatment here, which is nothing but a sequential combination of surgery, radiation, and chemotherapy. We follow this sequence. We do a biopsy to confirm the diagnosis. This is generally an incisional biopsy. However, if the tumor is very well circumscribed and localized, and you're not likely to disturb the extraocular muscles, then we can even consider doing a complete excision. So for smaller tumors, you can do a complete excision. Larger tumors, more infiltrative tumors, where you cannot spare the extraocular muscles, or you cannot plan your surgery without a biopsy. Basically, sometimes it can occur in young individuals and may look like other confounding clinical situations, then incisional biopsy is warranted. That is followed after confirmation of diagnosis by neoadjuvant chemotherapy for 3 cycles for optimal chemoreduction, followed by surgery, radiation, and adjuvant therapy in that in that order. So all patients undergo a baseline systemic evaluation, which currently includes a full whole body PET CT scan, transseptal incisional biopsy. We don't violate the periosteum at this stage. And one more principle of incisional biopsy is a direct approach. You will not do a lid crease incision for adenoid cystic carcinoma if you suspect clinically, and do a direct incision right over the tumor, which is generally a subro incision. Then we go ahead with intravenous chemotherapy, neoadjuvant with cisplatin and 5-fluorouracil for 3 cycles, followed by repeat imaging, then en bloc tumor excision, then extended field stereotactic radiation. This just does not include the orbit or the bed of the tumor, but also includes the inferior orbital fissure, superior orbital fissure, anterior part of the cavernous sinus with 10 mm safe margin over the pre-intravenous chemotherapy tumor extent. So basically, you go back to the pre-treatment tumor extent and tailor your or customize your radiation as per the pre-tumor tumor extent. Then adjuvant chemotherapy for 3 more cycles to complete 6 cycles of chemotherapy. The precautions that we take during incisional biopsy is that we do a multi-level biopsy. We don't just do a superficial biopsy, because often if the tumor is highly vascular and necrotic, then sometimes this superficial part of the biopsy may include just inflammation. The mid zone is generally very remunerative in terms of tumor yield, and deep biopsies often result in necrotic material. So we have to do both superficial, mid-level, and deep biopsy going past the epicenter of the tumor. That is very important. So radiologically, you determine the epicenter of the lesion, which is the middle of the lesion, and go all across beyond the epicenter with multiple biopsies. And that is how we get the correct diagnosis. Otherwise, sometimes these cases can be misdiagnosed as benign lesions or inflammation. Histopathology, of course, I'm not going to the details of it. This is an example of how chemoreduction is helpful. This is at the initial presentation. You can see the tumor is crossing the midline and is affecting the superior oblique muscle and to some extent the medial rectus muscle. Lateral rectus muscle is completely affected, and so is superior rectus LPS complex. Following neoadjuvant chemotherapy, you can see that the tumor has become much confined or consolidated. There is about 20 to 30% reduction in tumor volume. The tumor volume reduction is not just the only advantage. Neoadjuvant chemotherapy also makes the tumor much harder and consolidated, thus facilitating complete excision. So when we excise this tumor, we use a direct approach with a barrier sparing technique or bone sparing technique, where we don't excise the affected bone. Affected bone or orbitectomy implies that the bone is completely excised. We don't do a lateral bone cut at all, so that the tumor does not spread into the temporal fossa. We don't expose the dura by meddling with the roof so that the tumor does not extend intracranially. We spare the bone, yet do an en bloc excision, including the periosteum that is investing the tumor, and use this opportunity to implant leads for afterloaded brachytherapy. This is the surgical technique that we follow. You can see a defect in the bone, which is preoperative, of course, and we don't meddle with it. We don't excise it.
1 minute left, sir.
Sure. Sorry. I think I'm overshooting time. Sorry about this technical problem. Anyway, so can you see the video?
Yes, sir.
Yes.
All right. So that is the periosteum that is being incised. We take a 10 millimeter margin of the periosteum all along, and the tumor is excised along with the help of a cryoprobe. And that is the same patient following surgery. Following that, we deliver stereotactic radiation and adjuvant chemotherapy for 3 more cycles. So total 6 cycles of adjuvant chemotherapy. These are some of the results. You can see conveniently that the bone actually remodels. I'll show you that in a while. This is a very difficult case where there was a recurrence and extension into the cavernous sinus. Here, following neoadjuvant chemotherapy, there was substantial reduction in tumor, but nevertheless, tumor was still present. This patient had already received a good amount of radiation earlier elsewhere. So we decided to implant these silicon tubes, which carry a afterloaded brachytherapy isotope. Either iridium or strontium can be used as afterloaded brachytherapy isotope, which is delivered right to the bed of the tumor. Here we used iridium as the afterloaded source. And the results of multimodal treatment are quite encouraging. You can see here that where only surgery and radiation are done, local tumor recurrence is as high as 50% and systemic metastasis occurs in about 2/3 of patients. But when we do multimodal treatment, local tumor recurrence can be reduced to less than 10% and systemic metastasis to less than 5%, which is a substantial reduction in mortality. In addition, we can save the eye in about 95% of patients, avoid orbital exenteration, and also have a reasonable amount of vision salvage. So this is a much different prognosis than we used to have with tumor excision and radiation. So this is the case that I showed you earlier, young male. You can see how nicely the bone gets remodeled over a period of time. This is 1.5 years follow-up, bone is remodeled. And the young girl that I showed earlier, complete remodeling of the bone without having to excise the bone. So this is something that we have learned over years, that we don't have to meddle with the bone, excise just the tumor en bloc after chemoreduction, and rest of it is done by radiation and further chemotherapy. So in conclusion, I would say that the protocol for adenoid cystic carcinoma currently is safe biopsy with a direct approach followed by neoadjuvant chemotherapy, surgery, extended field radiation, and adjuvant chemotherapy with much better outcome. Thank you.
Thank you, Dr. Santosh, for highlighting the importance of multimodal therapy in cases where we actually didn't think we could do very much for these patients. So that is really heartening to see. We'll now move on to our next speaker. Let's welcome Dr. Pallavi Singh, an upcoming and promising young ophthalmologist from RP Center. She's going to highlight or tell us about something which is not as sinister as what we've just discussed, but photography in oculoplastics. I think with the advent of such good smartphones and so many tools, it would be very interesting to know how to get the best of them. Over to you, Pallavi.
Thank you so much, Dr. Sethi. I have a video that I had prepared for the talk. If you could just play the DOS people, if you could just play the video.
Sure.
Thank you. Good evening, everybody. I'm Dr. Pallavi Singh. I'm currently an ocular plastics fellow at the Jules Steiner Institute, UCLA. And I'm very thankful to my mentors, Dr. Neelam Pushkar and Dr. Namrata Sharma, for giving me the opportunity to speak at my home ground, which is the Delhi Ophthalmological Society. I'm here to talk today about photography and oculoplastics. And I feel as oculoplastic surgeons, photography is very important because part of our mission as oculoplastic and oculofacial surgeons is to create facial beauty. So it is important that the photography that we do brings out not only the technical aspects of the work that we do, but also the beauty of the face. And especially today in the age of Instagram, where we have a lot of plastic surgeons with their own social media handles and a lot of pre and post pictures, it's a good idea to know what a good picture should look like. And more often than not, we have a lot of before and after pictures, which kind of look like this picture over here. But hopefully by the end of the talk, I will give you a better idea of how to take a good picture and what exactly a good picture is. So what is the importance of photography? One of the obvious reasons is clinical documentation for our own medical records, but it also serves an important tool in communicating with our patients, in getting them to tell us what are the things that they are expecting, and for us to tell them the things that are possible. In terms of research, it's a great tool to harvest a lot of data for our presentations and publications. In terms of communication with colleagues, it's a great source. It's a great tool to let them know beforehand, give them an idea of what the patients look like and what the patient's history was. And also as surgeons, I feel the photography that we do represents the work that we do, and it represents a specialty. What is also important, apart from having a good, being a good photographer, is having a good filing system, because it's important to have all of our photos filed and ready for use when we need them. Now, one question which is often asked is, what is a good camera, or which camera is the best camera to use for professional photographs? But I think what we need to know very importantly, that the most important factors when it comes to good professional photographs are the lighting and the focal length of the lens. The camera in itself is not the most important aspect of photography, and it is not always necessary that the most expensive camera is going to give you the best photographs. So what constitutes of the ideal photograph? I think there are 4 factors that we're going to talk about over the coming slides that constitute good photograph. That is the head positioning, lighting, having a portrait mode, and having a background which is commensurate with the kind of work we want to do professionally. So when it comes to head positioning, it's important that the plane of the face of our subjects is parallel to the plane of the camera. As you can see here, the eyes should be looking straight ahead and the muscles should be relaxed. So this is what an ideal photograph would look like. And just to show you in the coming slides that even a 10-degree of head rotation can make a huge difference in the way the facial features are perceived, or in the facial features that are highlighted. As you can see, all these photographs are just different by 10 degrees of head rotation, but the eyes, the under eyes, and the nose look different in all of them. For oblique photographs, it's a good idea to have the tip of the nose touch the cheek. And for East Asian patients, we can have the nasal bridge aligned with the inner canthus to get our oblique photographs. For the worm's view photographs, it's a good idea to have the tip of the nose touch the glabella between the eyebrows. When it comes to lighting, there are many options available. We have the on-camera flash and we have the 2-point lighting. But with our experience, what we've seen is that the single softbox lighting is the most consistent, provides the most artistic pictures, and is economical as well. As you can see here in these 2 pictures, the subject is the same, the position is the same. The only thing that has changed is the lighting. The first photograph is the built-in camera flash, and the second photograph is the strobe light, which is mounted on a softbox. So we did a study here at UCLA talking about the effect of lighting on the perceived attractiveness of facial features. And what we found was that a superior box light, which was at an angle, which is at a superior angle of 45 degrees, provided the most attractive photographs, which is exactly the light that we use at UCLA. Over here, as you can see, the ceiling mounted strobe and the softbox. What is also another important factor is the lens focal length. It's good to have a telephoto lens that provides, that eliminates the distortion which might be seen with other lenses. And focal length of about 100 to 120 millimeters is an ideal focal length for the kind of photographs that we want to take. Just to give you an idea of what different focal lengths look like, this is the same subject at the same distance. It's just that the focal lengths are differing. And as you see that as the focal lengths decrease, there's more distortion. So for the kind of photographs that we want for our professional purposes, focal length of 100 to 120 millimeters is ideal. Also, it's important to have a simple and a non-distracting background. A photo mat board as seen here can be used. Now coming to the most important part of the lecture, I think it's very important to know what bad photographs look like, because we've talked about what a good photograph constitutes of, but unless and until you don't take a look at the bad photographs, you don't know what a good photograph is. So one of the most important problems that we see is an inconsistent head position. A lot of the publications we see in our own oculoplastic journals as well. As you can see here, the pre and post photographs of these two patients have very different head positions, which does not allow you to standardize these photographs. Again, a lot of Instagram plastic surgeons, they have their own handles. And as you can see here in the before and after, the after picture, the subject is all obviously away from the camera. And as we can see here, there's a difference in the rotation of her head. There's about a 10-degree difference in the rotation between the before and the after picture. Now that makes a huge difference in the way her facial features are perceived, and can distort our idea of what her final surgical result is. Another problem with photographs is inconsistent or harsh lighting. You can see the before is not well lit up and the after is. Again, different lighting, natural lighting in the first and flash lighting in the second. Another example from Instagram, where you have clearly different lighting for the before and after, which kind of changes the way we perceive the final result. Distracting background is something you just don't want to have. These are very unprofessional looking photographs. You don't want to have something of this sort in any scientific publication or presentation. And any uncontrolled lens distortion, again, in this case, you see the before and after. Pictures are very different because of the lens distortion. So to summarize, the ideal photograph is one that has standardized, consistent head positioning. It has soft artistic lighting, a non-distracting background, and preferably taken with a portrait telephoto lens.
So hopefully I've been able to clarify for you what a good picture is and how to take a good picture. And hopefully in the future, we'll be seeing more before and after pictures like this, rather than the picture that we started out with at the beginning of the presentation.
I would like to thank Dr. Goldberg, my mentor here at UCLA, for teaching me everything I know about photography. I would also like to thank my friend and colleague, Dr. Roloffs, for posing for me for this presentation. And a big thank you to my mentors at the All India Institute of Medical Sciences, Professor Neelam Pushkar and Professor Mandeep Bajaj, for being the best mentors one could ask for. Thank you.
Thank you, Dr. Pallavi, for giving us a very good picture of what our picture should actually be looking like. I hope, I'm sure all of us have picked up some good tips from that. Picture abhi baki hai.
Thank you. Nice to see the progress that you're making at UCLA, Pallavi.
Thank you so much, sir. Thank you so much.
Okay, so we now like to invite Dr. Lomi from RP Center to give us a talk on plaque brachytherapy for ocular tumors.
And then we will have another talk by Dr. Ruchi, which is in the final program. She'll be talking to us about perspectives on vision loss in mucormycosis.
Okay, so can I start now?
Yes.
Yeah, a very good evening to you all, respected chairperson, those organizing committee, and my seniors and my friends for this opportunity to share our experience of the Bhabha Atomic Research Center Ruthenium 106 plaque brachytherapy for ocular tumors. So I have no financial interest or disclosure in this presentation. So for the first time, the Bhabha Atomic Research Center of Mumbai has developed the indigenous Ruthenium 106 plaque, which has been started using in RP Center since started from last year, September, and is well appreciated and recognized by the Ministry of India. And this is the two plaque which we are recently using. The notch plaque, that is the dimension of 21 millimeter. The notch plaque is basically to use for tumors, intraocular tumors involving near the optic disc or near the fovea, in order to prevent radiation to these important structures. And the round dimension is 15.8 millimeter. So in the few months time, I will be expecting this another plaque model, this pediatric size, and also the ocular surface plaque too. So the highlight of this BRC ruthenium plaque is it's recovered from radioactive waste. It's simple and slim design. It's easy to use, and it gives a variable radioactivity from 250 to 1500 microcurie. And one plaque can treat about 50 patients. It's usable for 1 year and is cost effective. So coming to our experience, the first case scenario is a 2.5-year-old boy with a group D chemo-reduced retinoblastoma, which after 6 months, there is recurrence again. So you see here in this picture, very calcified lesions along with the intravitreal series were all calcified. However, there's a regression, there's recurrence is there in the edges. So we consider for the plaque brachytherapy in this case. So in this 3 months time, they saw a very good regression effect with this plaque brachytherapy. Another case scenario, a 4.5-year-old boy with a recurrent group C retinoblastoma, and other eye has been enucleated because of extraocular retinoblastoma. So out here, we have planned for brachytherapy, and the brachytherapy was done, and we see a very good results in the early outcomes. Another case scenario is this very quite interesting. A 12-month girl with a macular group B retinoblastoma who had received a standard 6 cycle of chemotherapy, and this has been lasered twice. Photocoagulation has been done around it. This has been done from outside, and this patient has been referred to us. For the first impression, we'll think of to go for intraocular chemotherapy. However, this has been already lasered the surrounding, so we have considered for the plaque brachytherapy in this case. And this is the calculation, dosimetry calculation done by the medical physicist with a usual dose at apex 40 gray, and the application duration is 11.3 hours. And the scleral dose is 176. So this is the post-op 2 months period. We see the good regression. Still some areas are still active regression pattern are there. So the patient is still on follow-up. This is a case of choroidal melanoma with a tumor thickness of 5 millimeter. And the largest basal diameter is 11.2 millimeter. So here also we consider plaque brachytherapy. So in 4 months time, we see a very good reduction in the size of the thickness. From it has gone to 2.1 millimeters, and the vision has been maintained. Another case of choroidal melanoma, which is pretty large enough, 6.2 millimeter of thickness. Here we know that the ruthenium-106 plaque is feasible for the tumor thickness of less than 6 millimeter. If we got this iodine-125, that will be a better option here. But we have done another option here, treatment with this combined this plaque brachytherapy along with the transpapillary chemotherapy, the sandwich technique, and see the good results. This good tumor reduction is seen. Another case with a large choroidal melanoma, apical thickness 6.9 millimeter. So here also similarly we have done this combined procedure, the plaque brachytherapy along with the transpapillary chemotherapy, and the tumor control is still there. We see a few subretinal exudates are there. However, we expected it will go off in mean follow-up times. A case of diffuse choroidal hemangioma with a vision 3/60, you see a extensive serious retinal detachment, and vision is 3/60 here. So here also we have considered for plaque brachytherapy, since this is not considered for the photodynamic therapy because of the high elevation of the retinal detachment. So this results at a 3-month post-op, we see the regression of retinal detachment is there, and then even the thickness also reduced to 2.8 millimeter. Another case of diffuse choroidal hemangioma with extensive retinal detachment here. You see the retinal vessel just behind the lens. So out here, we plan for plaque brachytherapy. We see that the largest area where the tumor choroidal thickness is, it is 3.4 millimeter in the thickness. So we consider for brachytherapy in this case. So this is a 2-month post-operative. There's a reduction in this serious detachment, and still there's some shallow detachment is there. The patient is still on follow-up now. Another case with Sturge-Weber diffuse choroidal hemangioma, we consider for plaque brachytherapy. This is the 8 months follow-up, and some scarring have come out. There's regression of the retinal detachment here. This is a last case, the ocular surface tumor, ocular surface squamous neoplasia. So this has been handled with a conservative conjunctival mass excision. Usually, this case is a case of there's immuno-reduced after interferon for 2 months. So we have done this excision of this conjunctival mass along with this cryotherapy of the edges and the on and base, and along with the amniotic membrane graft. So in the histopathology slide and also in the anterior segment OCT, we find there's a residual lesion there in the sclera. So we consider for plaque brachytherapy here in this case. And this is the as a 2-month post-operative follow-up, and this is the post-op at 3 months. So there is a good tumor control, and even there is no any sign of recurrence so far in this follow-up. So coming to compare this BBIC, the German company of Ruthenium 106 and our indigenous Bhabha Atomic Research Center Ruthenium 106, we have done 38 cases on BBIC and then BRC 17 cases, comprising of retinoblastoma, melanoma, OSSN, and also benign lesion like hemangioma, retinal angioma, and then vasoproliferative retinal tumors. So in this, we see the good tumor control rate at 6 months of 91%, and BRC is around 100%, and the tumor control rate at 12 months for BBIC is around 85.29%. So in conclusion, the BRC Ruthenium 106 plaques offer a viable option for management of ocular tumors. Early results is very encouraging and is at par with the internationally available Ruthenium 106 plaques, and the plaque handling is also very user-friendly and is very cost-effective. Thank you all for your kind attention.
Thank you, Dr. Lomi. It is really heartening that we now have the plaque available and we are able to save so many eyes and so many patients whom we couldn't earlier do. So that's I'm so happy that you're doing so many cases and so many patients are benefiting from it. I'd now like to invite Dr. Ruchi Goyal. She's going to give her insights on mucor-induced blindness. And I must say, this is something which has troubled most of us for the last 3 to 4 months. Even today, I've had to do one exenteration. So we really would like to hear about your insights, and maybe we can all then do, some more. Hopefully no other waves come, but we can all do some more to save these patients. Over to you, Ruchi.
Yeah, my slides are visible now?
No.
Yes, it's visible. You can go ahead, ma'am.
Not, ma'am. Please share, ma'am.
No, I
फिर
can't
से बंद हो गया. आपने अपने फोन से किया है, मैम?
No. I've not done it. I'll share it again.
Yes, please. In the meanwhile, for all the other attendees who have just joined in for the next session, apologies, we are a bit delayed. We shall be getting started soon. Thank you.
Okay.
Yes, ma'am, we can see it. You can get started, ma'am.
Yeah. So I think the last few months, we were all really struggling with this influx of the mucor cases. So, I just, while it's being a nasal disease and we are also extensively involved because of the vision loss, and the patients are still trickling in. So just to recapitulate from where actually the orbit is getting involved, the main reservoir, of course, is the pterygopalatine fossa, and from the inferior orbital fissure, there is one route where it reaches the orbit and it goes to the retroglobal space after that. And the other common route which we've found was the anterior ethmoidal vessels, from where actually the fungus was entering the orbit. And there was a retrograde spread also seen through the nasolacrimal duct, the lamina papyracea, and the most important was the vascular embolus, because this was a really angioinvasive fungus. Now, we are all aware of these different presentations. I'll not go into the detail, but the most alarming, of course, was the ophthalmoplegia and the vascular occlusions, which were really, we were losing eyes like anything. Now, I came across so many patients where I could see the orbital apex syndrome and the vascular occlusion, which was common. In literature, it was reported that there could be 16 to 20% incidence of vascular occlusion. These are a couple of cases, I think, which we all have been seeing. This was a typical presentation where you would have a RAPD and, there was no movement of any of the in any of the versions or any of the ductions. And these were young patients which we were losing again and again. The vision was going. Then there were patients who had hemiretinal artery occlusion, the other eye showing ischemia, despite the fact that the orbit was not too much involved. Now, after seeing so many patients, another patient proptosis, and these were the orbit was full of, and you were trying to save, and we were really worried what will happen to the other eye. Some patients you could not even see the fundus. Here, this is a patient who again had CRO, appeared to be an CR resolving CRO, and she had facial palsy developing after that. Another patient with orbital apex syndrome, and this is CRO again. Then this is a patient where the entire globe has collapsed. And so what I did was I started doing color Doppler of these patients, and I found that there was reduced flow in the ophthalmic artery in almost all these patients, and in the central retinal artery there was no flow. So I thought, yes, these are probably all central artery occlusions. Then some of the patients had to undergo orbital exenteration, and to my surprise, what I found was that in all the patients, there was one thing in common, and that was that the ophthalmic artery was thrombosed. There was ischemic thrombosis, and it was nearly full of these mucor. You can see these aseptate mucor filaments in all these patients. The other thing that I found was that there was optic nerve ischemia, but in many of these patients, actually the central retinal artery was intact and patent. So this again put me to thinking what has really happened. There were a couple of patients where the globe was involved and the fungus had invaded the coats, like this one. This is the lens which is surrounded by the inflammatory exudate. The globe has collapsed. So, I started thinking, so possibly what had happened was that the first thing that it was that, of course, the orbital apex was involved by the direct invasion of the fungus, and along with that, possibly the optic nerve ischemia, which was again not 100% in all the patients where the exenteration was performed, but many patients, it was a combination of compression of the pile plexus in the optic canal, and of course there was compression of the optic nerve directly at the orbital apex. But when it comes to actually the vascular involvement, it was first the ophthalmic artery thrombosis that was occurring, and that had led to the flow being stopped to the central retinal artery that we were seeing all those kind of clinical pictures. So just to conclude that, simply seeing the fundus at a glance, we really need to look, because if you look back, all these patients, they had lot of pallor of the, if you look back again, there was a lot of ischemia of the fundus, which possibly we had missed, and we had simply thought it was CRO. So these are, all of them were actually ophthalmic artery occlusions. We have already sent this, it is under publication, and these are, I'm not going into details. These are a couple of, literature which we have presented, and these are articles which are published in Clinical Ophthalmology American Journal. These are all from our group, and anybody who's interested can go through it. More are in pipeline, and this is all. It was a very surprising finding which I came across, so I thought I'll share it with everyone. Thanks so much. I will not take anybody's time.
Thank you. Thank you, Dr. Ruchi, for that wonderful insight. We all know that presentation with central retinal artery occlusion or with no PL is much commoner than the 10-15% you cited from the literature, and we see them ever so often. And it's good to know what possible mechanisms may be at work. I think we'll take this opportunity to thank everyone. I don't think we have any more time for discussion. We started 10 minutes late. We would hand over 10 minutes late. And would like to thank all my co-chairs and conveners and all the speakers for some wonderful presentations and a great discussion. Thank you very much.
Thank you, everyone.
Thank you. Thank you, everyone. Thanks.
We would like to move to the next session. For the next session, we have our moderators and the chairpersons with us. I request the moderators and the chairperson and the co-conveners to please unmute themselves. We have our first speaker with us, Dr. Asha Samdani. I would request the chairperson, Dr. Santosh Honawar, if he's present with us, to please unmute himself. We've also got, for sure, we've got our co-chairperson, Dr. Urmil Chawla. Dr. Urmil, can you hear me? Dr. Asha, we can see you. Could you please start your video, please? Hi, Dr. Asha. Hi. We have our chairperson, that is Dr. Santosh Honawar. We've got the co-chairperson, Dr. Urmil Chawla. We've got convener, that is you itself, Dr. Asha Samdani. We've got our co-convener, Dr. Seema Das, the moderator, Dr. Pankaj Gupta. We've got the panelist, Dr. Bhavna Khurana, Abhijit Ransal sir, and Gunjan Saluja sir. So I request the panelist, the chairperson, the co-conveners to please unmute themselves. We're still waiting for a few people to join in. But in the meanwhile, with respect to the time, we're already 16 minutes delayed. Can I request Dr. Asha to please start her screen sharing and start with the presentation, ma'am?
Sure.
I believe Dr. Pankaj Gupta sir is with us. I request Dr. Pankaj Gupta to please bear with us and introduce our next speaker as well. Our next speaker is going to be Dr. Seema Das.
Are my slides visible?
Yes, your slides are visible. Could you just put it in the, yes, you're good to go, ma'am. Dr. Pankaj, with your permission and request, can Dr. Asha go ahead?
Yeah, please.
Thank you, sir. Over to Dr. Asha.
Yeah, thank you. I'm Dr. Asha. I'll be talking about definition and common canalicular blocks. So first of all, what is a distal canalicular block? Distal canalicular block is something which is in between 5 to 10 mm from the punctum, and common canalicular block is greater than 10 mm from the punctum. It's a soft block. So what can be the causes of common canalicular blocks? It can either be congenital or acquired. In the acquired causes, it can be varied number of causes. It can be idiopathic, trauma, infections, cicatricial lesions, in medications. So what is the treatment? So it is the treatment is different if the obstruction is partial and complete. So if the obstruction is partial, maybe a forceful syringing can be done, and intubation with silicone tube and steroids, milder steroids can be started. If the obstruction is complete, you may have to relieve the obstruction before doing anything else. And the site of obstruction is also equally important, if it's proximal or distal. If it's a proximal block, we are not left with much options. We may have to go ahead with conjunctival DCR with a Lesterzone's tube. And in distal blocks, we can do, we have few options like canalicular DCR, laser canaliculoplasty, and balloon dilation. So this is the instrument I'm going to talk about. This is a lacrimal trephine needle. This is a 21 gauge needle. This is the and this has a plastic handle, and this is the metallic stylet. It has a plastic hub attached, and it has a luer lock system. So this is the lacrimal trephine needle. This is covered with a plastic sleeve here. So this is the magnified view of the same. We can see that the edges are a little sharper, and this helps to bore us through the obstruction. What are the other uses of mini trephine other than common canalicular blocks? Is the removal of scar tissue, biopsy specimens, and drainage of the cysts. So this is the monocanalicular stent. After relieving the obstruction, we are going to place this in the system. So this is made of silicone, and the tube is almost of a diameter of 0.64 mm. As we can see here, it has a head bulb which will plug the punctum. It can be securely anchored at the punctum, and the sutures and knots are not needed. So here I would like to play a surgical video. So after giving a local block with xyloadri, the punctum is dilated with the help of a Nettelship's punctal dilator. Then post this, we put a Bowman's probe and confirm the obstruction. After feeling a soft block, we measure the obstruction after holding with the help of a forceps. Here we are measuring the obstruction from the block. It's almost 10 to 11 mm, so which suggests that it's a common canalicular block. Now we have put the trephine along with the stylet. After filling the block, we remove the stylet as seen. And now with the help of the plastic hub, we advance it in a screwing motion clockwise and anti-clockwise till we relieve the obstruction of soft block and we reach the hard stop. So here we are continuing the screwing motions, being gentle. Once the hard stop is seen, we retract it a little and then put saline and check for the patency. Now we can see that the saline is moving, and we have asked the patient if he can feel saline in the throat, and the answer was yes. So yes, the obstruction was relieved. So now we have put mitomycin 0.04% here to keep the open, and it works as an antifibrotic agent. After mitomycin, it's important to do a saline irrigation and flush the mitomycin. And this is the monocanalicular stent which we were talking about. It is trimmed accordingly, according to the length. It is inserted through the punctum and channeled through the canaliculus. Sometimes it fits very easily on the punctum, as we can see here, but sometimes fitting that may be difficult. In that case, we can use a Bowman's probe for the help. It acts as a guide for the stent placement. After it's placed and its position is secured, we can augment it with the help of a Weichel suture. The Weichel suture is not mandatory in all the cases. So this slide highlights the same steps after the dilation of punctum and the level of obstruction confirmed by probing. The hard scar tissue will be removed, and later this monocanalicular stent which is placed, it is a self-retaining stent, and it should be placed almost for 6 weeks to 3 months. So this is the post-op of the patient, where we can see that the stent is in situ, and this is a magnified picture of the same. After 3 months, the monocanalicular stent can be removed as an office procedure under slit lamp. This is the pre-op in which tear film height is increased, and this is the post-op 6 months later, which there is a tear film height is decreased. So clearly there is a relief of the obstruction. So what are the complications? The most common complication seen in monocanalicular stents is the stent extrusion. Sometimes even after the anchoring, we can see that the stent extrusion is quite common. And one more complication is a granuloma. Sometimes a granuloma can also form in after post stent removal. So here I'm mentioning a few studies in which distal obstructions have highest degree of relief of almost 80% success rate, followed by the bicanalicular and common canalicular. And other studies also show good success rate in this definition in a CCB block. And we have also seen in our study done at our center that there is no significant difference in functional and anatomical outcomes with MMC, with mitomycin at the end of 6 months. Thank you, everyone.
Nice presentation. But are you not finding that after 4 or 5 months, there are patients who are again coming with the troubling epiphora? At least I have seen in my cases, few of them. Initially,
Yes,
they're
ma'am.
giving good results, but sooner or later, by end of 5-6 months, I have few cases who are coming with the recurrence. That's why I'm asking you.
Yes, ma'am. Actually, I have seen in maybe I can say 1 in 10 cases, I have seen an obstruction, but we have repeated the procedure next time with a mitomycin. In that, again, fortunately, we could not see any recurrence. Ma'am, I would also like you to ask, did you use mitomycin in the cases?
No, I haven't used mitomycin. I plan to use now, but I've been doing simple trepanation.
Okay, okay.
Maybe that must have been one reason. I'll also try that.
In the meanwhile, I request our next speaker, Dr. Seema Das, to please start her screen sharing. Over to the chairperson. We can see your screen, ma'am. Could you just put it in the presentation mode? Yes.
Yes. Visible.
Yes, ma'am. Yes, ma'am.
So very good evening to everyone and to all the brave hearts who have kind of, stayed back after a long day. So I'll be talking about retinoblastoma management beyond what we do in the clinic. So we all have seen in the previous sessions that, there are various treatment modalities now available for retinoblastoma. And right from the initiation of intravenous chemotherapy with the now intra-arterial chemotherapy available, which has given excellent result in eye salvage, even for advanced intraocular tumors. And now with the advent of intravitreal chemotherapy as well as plaque brachytherapy, the outcome of intraocular tumors has really become much better, and we are able to save many more eyes. But the problem is that in our setup, we still continue to see the patient at this stage. At least in our setup, at least in northern part of the country, majority of our patients, almost about 40 to 50%, are going to present at an extraocular stage of tumors. And this has actually become worse post-COVID pandemic, especially probably related to the delay in the diagnosis as well as the travel restrictions because of the lockdown and other things. Now, at this stage, all your advanced treatment modalities, whatever you have, are useless if you're not able to detect the tumor on time. Now, for example, this child we recently saw, he was diagnosed last year in January 2020. They noticed this white reflex. In fact, they noticed it way before that time, but in January 2020, they had consulted at Tertiary Care Eye Hospital. They were advised an MRI, but possibly because of the COVID, many centers turned him down. They were also not very serious about the kind of, gravity of the situation and kept on delaying the imaging. And by the time the patient had come to us, this is what the situation was. The small tumor inside the globe, barely any proptosis, but look at the optic nerve, it's all thickened almost in the apex. So this is a tumor where kind of, the life salvage becomes a very kind of difficult situation. And if this tumor was detected at a little early stage, somebody would have guided them a little better. Probably the outcome would have been much more better. Same for this child who was diagnosed as thysis valvi, advised an evisceration post-trauma. But unfortunately, nobody did a V-scan. Now, when we saw this child, the lens was dislocated into the anterior chamber. Possibly that was the reason why it was attributed to the trauma. And we can see the calcification on the B scan. So this is a regressed retinoblastoma, which unless and until we know the clinical presentation, we are going to miss it. So there is a need to have early detection and a timely referral to know the various presentations. And we know white reflex is the earliest thing which we see in retinoblastoma. And if you're able to detect the tumor at this stage, if not the eye, most of the time you will be able to save the life of the kid. And this is something which can be very nicely done if somebody just does a red reflex screening, which can be done with simple ophthalmoscope, the small pocket ones, which even the pediatrician can carry, or simply by asking the history to the parents if there is any white reflex, or sometimes even by looking at the photographs. Any white reflex is an urgent referral, unless and until proven otherwise, it's a retinoblastoma. So just increasing the awareness about the white reflex is something which is required if we have to ultimately improve the outcome of these children. Despite having all the treatment modalities, the outcome still remains poor, probably because of this reason. So what we did here at Shroff, and we have our affiliated secondary centers, which are in the kind of, vastly populated UP and the surrounding states of Rajasthan and Haryana. We tried to increase the awareness, at least among our cadre of eye healthcare workers, especially the community health workers who go down to the community, do door-to-door screening, including the Asha Anganwadi workers. Just as a pilot, if we train them kind of, to ask about white reflex, and we also use this device called ArcLight, which is a small pocket ophthalmoscope sort of device, very cheap, very affordable sort of thing. And this is something which works very well for detecting the red reflex. It can be done even in the house of the patient. When the community workers go for the screening, can do a quick screening, doesn't need dilatation of the pupil, can be done even on the undilated pupil. And this is the number which we have trained over the last 6 or 7 months or so. Majority of these are community health workers, including few about 50 to 60 ophthalmologists also. We also created some referral cards, referral pathway, had a centralized referral number, distributed awareness material among all the community health workers, among the vision center technicians. And this is what would be the possible impact. Now, after training in one of these workshops, one of the community health workers, vision technician, was working in a vision center, detected this child to be having a white reflex in the eye. The child was referred to one of our secondary centers. And unfortunately, when we saw the child did the UA, this eye had a large tumor, probably not salvageable. Even the other eye had a small tumors. This is how the tumor was in the worst affected eye when it was detected. But as part of the sibling screening, we got to know that this child has another sibling who is just about 1 month old. So we screened this sibling also, and we found a small tumor in the sibling also. Now, fortunately, this tumor is so small, just with focal therapy, we can take care of it. So this could be the possible impact of just making the kind of the workers who are working in the community to make them a little more aware about the retinoblastoma. Otherwise, these are the situations which we get to see more often, again, because of the delay in the diagnosis, not able to get a MRI done on time. This was another child where there was a delay in almost 1.5 years just to get an MRI done because there are financial issue and of course other issues because of the restriction of the COVID and all the other things. So it's important to identify the treatment barriers and address them if we have to improve the outcome. So routinely we do family interview for all the patients who come here for treatment, and we have identified many barriers, most of them related to the travel support, especially in the last 1.5 years. Accommodation support is required for many of them. Treatment support, especially for MRI and other things, are also required. And counseling specifically, which is aimed at improving the compliance, is something which is required repeatedly for many of these children. Now, this child and another one who comes from the district of Alwar, they were partially treated, but again lost to follow-up because they could not travel during the lockdown time. So we actually had to arrange a pickup for the child from the home, got the child here on time so that she could get the enucleation on time and does not come back to us with an extraocular tumors. So these small interventions have shown very promising result, and this is our data. In September till date, we have treated about 60 children in this calendar year, and we could identify treatment barriers in about 36 of them. And when we did intervention for those barriers, the treatment compliance actually improved to 93%, and this is way more than what it has been there.
1 minute left, ma'am.
Yeah. Another thing is important to address is the prosthetic rehabilitation, which we do not talk very commonly here. So many of these children study by quality of life is adversely affected. Of course, we know if the vision is poor, and especially the eye, which are affected. So in this child to the mainstream, like this child who were trained to use Braille, and there are now smart vision spectacles and many other technology available, the disability certificates, which we routinely need to take care and make sure this child go through them even after the completion of treatment. The last bit, genetics, is something which has come up very, very strongly, and it is going to become stronger in the coming years. Unilateral RB, aggressive RB in a small child, we enucleated the eye, did a genetic testing, was diagnosed as a germline mutation, and we know that the other eye has a chance of getting this tumor. We kept the child on very frequent follow-up, almost monthly follow-up. Down the line, 3 or 4 months down the line, a small tumor comes up in the other eye. We could do a laser immediately, take care of the tumor, and this is where the genetic testing plays a very important role. Another area where genetic testing plays a very important role, elder sibling bilateral RB, the younger one detected as bilateral RB again, but small tumors, we could say both the eyes. Father, we can see is blind. The mother was again pregnant. We did a genetic increase, a new CBS for the mother, and we could identify.
Dr. Pankaj, if you could invite the next speaker. I believe we've lost.
Can I please take a minute and finish?
Okay. Yes, ma'am.
Yep, stop.
In between, we lost you, ma'am. We couldn't get your connectivity, ma'am.
Is it better now? Because my screen has gone.
Yes, ma'am. There's some internet issues that we could see. Nonetheless,
again.
Can you share your screen now? Can you share your screen? We can't see your screen.
Yeah, I didn't share it. I thought because you have stopped the screen sharing. Is that okay? Visible now?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes. So this is one important area where genetics plays a very important role, because the mother, when she was pregnant, was diagnosed as the child was carrying the mutation based on the CVS, chorionucleus biopsy. We counseled the family for the termination, but unfortunately, they were not ready for termination. But at least now we know that there is a high possibility the third child is going to get it, and it's a very early screening as soon as the child is born, so that we're able to diagnose the tumor on time. So these are some of the things which we need to take care when we talk about RB. It's not only just treating them in the clinics. They need a lot of hand-holding beyond the clinics if we have to ultimately improve their outcome. This is our team, and thank you for giving me this opportunity to share the work.
Thank you, ma'am. Thank you for a comprehensive talk. Very nice. I think we'll have the questions in the end. Dr. Pankaj, would you just invite the next speaker, please?
Yeah. I would now request Dr. Nripan Gaur to begin with his presentation. Dr. Gaur, can you share your screen now?
Yes, yes, sir. Are my slides visible?
Not, sir, please
No,
share
your slides are not visible. Please share your screen.
Yeah.
We shall update you the moment we could see it. In the meanwhile, with respect to time, we are already 15 minutes delayed. Dr. Gaur, are you able to share the screen? If you need any assistance, the Grover AV team is right here to help you out, sir.
Sir, first of all, open your PPT, then click on share screen.
That's Atul from the Grover AV team who's talking.
Yeah, I'm trying to share.
Yes.
Click on share on Zoom.
Yeah, are these visible now?
Not yet, sir.
You're not shared
Not
screen,
yet.
sir.
Yeah, in the meanwhile, can the next speaker talk? Start his talk?
Okay.
Just,
Okay. Is Dr. Manu Saini there? Dr. Manu?
Yes, sir. Yes, sir. I'm sharing my slides.
Yeah. I'll request Dr. Manu to begin with her presentation.
We can see your slides, ma'am. Could you just put it on the presentation mode?
Yes, yes, I'm doing it.
Yes. You can go ahead, ma'am, after you put it on the yes, you can go ahead.
Thank you for joining me today on this evening. I'm going to talk about congenital ptosis, management, and outcomes. My slides are not moving. Let me see. Yeah. Blepharoptosis is defined as abnormal low positioning of upper eyelid margin in primary position or asymmetry of more than 2 mm between the two eyes. Surgical intervention is required for imminent risk of amblyopia for improving vision and aesthetic concerns. Levator is one of the key factors in determining the severity and selecting appropriate treatment protocol. In addition, management of the congenital ptosis depends on laterality, associated disease, and surgeon's experience in decision making. So successful ptosis surgery depend on accurate understanding of LPS aponeurosis anatomy. LPS aponeurosis was formerly considered as a uniform single-layered structure. However, subsequent studies reported that LPS aponeurosis is divided into 2 layers, superficial layer and deep layer. Superficial layer reflected upward in continuity with orbital septum, and deep layer extend onto the anterior tarsal plate. Superficial LPS aponeurosis is immunonegative for smooth muscle antigen, whereas deep layer is positive. 2 layers can be appreciated near the superior border of the tarsal plate. An important point to emphasize is the deep layer, which is an anatomically significant layer to improve the aesthetic outcome. Therefore, during ptosis repair, needle should pass through this deep layer. Surgical modalities for the correction of the ptosis are volar muscle conjunctival resection in mild ptosis, depending upon the response following installation of the topical phenylephrine, levator plication, levator resection, and frontalis suspension. But what we have in the literature is about resection. There is no universal method described to quantify the amount of levator plication in ptosis repair. So we are using the same guidelines with few intraoperative adjustments. A short video of levator plication. Lid crease incision is made at the same level as of the other eye. Orbicularis oculi is dissected out from center to the periphery. Thin sheet-like structure and underlying pre-aponeurotic fat pad are identified. Orbital septum is incised from center to the periphery. Underlying pre-aponeurotic fat pads serve as a guideline for identification of LPS aponeurosis. After retracting the fat pad, fine adhesions are removed with the cotton-tipped applicator. LPS and the Whitnall ligaments are identified. Amount of levator to be plicated is marked with the gentian voilate. 3 non-absorbable double arm sutures are passed. The bite should be deep enough to include the tarsal plate and deep layer of aponeurosis. Center bite is passed first. Check the lid height and the contour. When the desired height and the contour is achieved, then hoga, lateral and medial sutures are passed. Ensure that the needle should not include conjunctiva. And then final knots are tied. Later, lid crease sutures are applied, taking bite through the LPS aponeurosis. Skin is opposed and frost suture is applied. This is a clinical photograph of congenital mild ptosis with good LPS section. Levator plication is performed. Good lid height and contour is achieved. Similarly, LPS plication was performed in moderate congenital ptosis with fair LPS action. Satisfactory outcomes were achieved. Therefore, transcutaneous levator plication approach serve as a simple, safe, effective, and versatile procedure for the correction of mild to moderate ptosis with LPS function of 5 mm. Correction of unilateral congenital severe ptosis with poor LPS section is a challenging, particularly in terms of achieving symmetry and cosmesis. In these conditions, maximum levator resection can be done. It has an additional advantage over frontalis suspension in terms of presence of dynamic blink, preservation of the natural eyelid contour, lack of reliance on the brow elevation. The cutoff limit mentioned for maximum levator resection is of 4 mm. This 5-year-old girl presented with a case of residual DVD, and she has a congenital severe ptosis with poor LPS section. Maximum LPS resection was done with set target of equal vertical fissure height, and good results are obtained. A variant of the maximum levator resection described by the Lee et al. Is in their study, what they did, the transection of the medial and the lateral horns were not carried out to elevate the lid more than the cutting both horns. So satisfactory outcomes were noted in their study. Frontalis suspension should be reserved for congenital severe ptosis with poor LPS action. We have a variety of grafts or implants, implant means which we can use for frontalis suspension. But first choice is autologous fasciolata, which we prefer to perform in older persons. But this study recently published from the Spain used autologous fasciolata in children under 3-year-old, and satisfactory outcomes they documented. Thank you for your kind attention.
Thank you, Dr. Saini, for the excellent presentation. Dr. Chawla, your comments, ma'am.
Dr. Saini, have you had any experience with supramaximal LPS resection?
Yes, ma'am. Supramaximal resection can be performed with poor LPS section too.
Yeah, and it has definitely got good results.
Yes, ma'am.
So
yes.
I prefer to do a supramaximal over sling surgery whenever a choice, like even at 4 I would prefer to go for a supramaximal rather than going for a sling, because I'm really getting good results with the supramaximal, and maintenance of the lid crease is one of the most important plus point for that.
Lid lag, lag of the box.
Yeah, and another thing, LPS plication is definitely a very promising procedure, especially for the mild ptosis, but especially for the moderate one, given a choice, I would definitely go still for LPS resection over the plication. So different, I agree. I've done a lot of plication, but still, I would prefer my personal choice would be going for the moderates one. Mild, definitely, I agree. It was a very nice presentation, comprehensive. Thank you. Let's go to the next speaker.
Dr. Gaur?
Yeah, I'll be trying once again.
There will be a greenish icon in the...
I think...
yeah.
My screen visible now?
Sir, you're not shared right.
We can only
right
see a
window.
white screen. There's nothing written or anything there.
Okay, just a
I
second.
can see the screen. Now the screen is also gone.
Yeah.
Yeah. Now we can see the screen. Please begin with the presentation.
Good evening, everyone. I'm sorry, apologies for the errors. So I'll be talking about lacrimal fistula.
Please click on center.
So I'll be taking a case-based approach here, and I'll be mainly concentrating on the congenital fistulas. So we had this 7-year-old male child who presented to us with watering from an opening on the skin near the eye, which was present since birth. There was no discharge, no swelling. There were no signs of inflammation. We can see here the opening is present on the infero-nasal aspect of the medial canthus. So how do we approach these cases? So we should take careful history taking. We should note all the sequence of events which lead to the present pathology. We should do a comprehensive slit lamp examination. We should look for skin opening, punctum, cul-de-sac, lex lacrimalis, tear meniscus, and we should also look for any sac regurgitation. We should also do various tests for tear drainage system, because we have to rule out any concomitant nasolacrimal duct abnormality which might be present. I won't go into the details about this test. So basically, lacrimal fistula is classified into two types, congenital and acquired. So the congenital ones, in this kind of patients, we don't have any sequence of events, and usually they don't have major apophora. Whereas in acquired lacrimal fistulas, the patients usually have a history of painful swelling, dacrocystitis or sac abscess. Some of them may be having a history of incision and drainage, which might be done for this dacrocystitis. So there are a few theories which have been given for congenital lacrimal fistula. First one is the accessory or supranumeric canaliculi theory, which has been given by Jones and Wobbing. Much more wider accepted theory is that of the extra canaliculus, which is caused by abnormal budding of canaliculi rather than the persistence of enlarge. So a bit more about this disease. It is very rare. Incidence is just 1 in 2,000 births. It is mostly unilateral. The lining of these fistulas is lined by stratified squamous epithelium cells. The internal opening usually opens into the common canaliculus, followed by sac, NLD, and canaliculus. Mostly we have a patent NLD. It may be associated with various syndromes, and we must do a comprehensive systemic evaluation also to rule out these syndromes. So in our case, we made a diagnosis of congenital lacrimal fistula with patent lacrimal drainage system, as there was no discharge and all the tear drainage tests were normal. So coming to the management, so if the patient is having no symptoms, so we can follow these patients up and do a conservative management. However, in symptomatic cases where we have watering from the fistula site, and there may be some cases where the patients are very much apprehensive about the opening present in the skin. So in these cases, we can go ahead with the fistulectomy, which was the modality we chose for our patient. So this is the surgical video here. So before doing the surgery, what we do, we have to look for, we do syringing and to rule out any concomitant NLD which may be present. In this case, we can see this was completely patent. After confirming this, we take a Bowman's probe and we put it in insert it in the lower canaliculus. This is done to protect the lower canaliculus from any iatrogenic injury which might be caused. We insert another probe into the fistula opening. A metal to metal touch is noted, and this helps us in ascertaining the extent of the fistula. So once this is done, we may mark the incision of the site. So incision is made using 11 number blades. So the incision is then deepened. And now we can see that this second Bowman's probe, it is being used as a guide wire. Basically, it would tell us the extent, and till the extent we can excise our fistula. Now we are dissecting it. So once the dissection is complete, then this entire fistulous tract along with skin is taken out as a cuff of tissue. So the wound which is present is then closed with 60 Vicryl sutures. So this is the image after the surgery. So this was the picture on the post-operative day 1. The diet disappearance test was normal. The patient had no complaints whatsoever. There were no significant inflammation. There was no ectropion or lid margin notching. So the take-home message is history and clinical examinations usually tell the etiology of fistula. The choice of surgery depends on the etiology. So basically, if there is no neck-limal duct obstruction, then we don't need to do a concomitant DCR, as only a fistulectomy can suffice. Syringing and probing should be done at least once before the surgery. Most cases of congenital lacrimal fistula do not have lacrimal outflow obstruction and can be managed successfully by simple excision. This was from a study published in 2014 in British Journal of Ophthalmology. The 2 probes guided fistulectomy is essential to prevent the canalicular damage, as we showed in this surgical video. So this was in brief about the management aspect and the evaluation aspect of the lacrimal fistula. Thank you.
Thank you, Dr. Gaur, for the presentation. Over to you, ma'am. Dr. Chawla.
Thank you, Dr. Nipin. It was a very nice presentation and nicely done surgery also. And as you know, the incidence of these fistula is not very high. Yes. And you're right that generally the NLD has been found to be patent. Yes. So we are able to carry on with and most of them, not most of them, but quite a lot of them are asymptomatic also. Mm-hmm. And we should always be careful about detecting that supernumerary canaliculi. We should be very careful about that, because that will definitely change your mode of treatment also. And it gives a good result with the fistulectomy alone also if the NLD is patent. But I have had one case in which the NLD was not patent. So we had to do a DCR along with that. And that too came out to be having a good result. So it is a good procedure and it gives good success rate also. Thank you for a nice presentation. Any other panelists are also welcome to give their comments, please.
As there are no other comments, ma'am, shall we proceed to the next presentation? Please. I would now invite Dr. Bhavna Khurana to please begin with her presentation. Dr. Khurana.
Is my screen visible?
Yes, it's visible and you're audible. Just put it on full screen.
Good evening, everybody. Yeah, I'll be presenting on thyroid ophthalmopathy, latest management recommendations. Thyroid ophthalmopathy is, as known, it's an autoimmune disorder with the disease transition from active progressive period to stable inactive fibrotic stage over 1 to 3 years. It is seen in about 40% of patients with Graves' disease. Though it's most common in Graves, it can occur in hypothyroidism, euthyroidism, and Hashimoto's thyroiditis. It occurs due to infiltration of orbital fat, extraocular muscles, lacrimal gland by lymphocytes, leading to activation of orbital fibroblasts and deposition of glycosaminoglycans. It is because of shared antibody antigens and cross reaction of
यार
thyroid
वो
and orbital tissue.
डॉक्टर अभी भी दो ना, एक देखें डॉक्टर मिलिंद चांगोले is in the this thing promoter panelist ले बाबा.
So insulin-like growth
रहने
factor
देना
1
यार,
is
कल कोई कंप्लेन कर देगा यार, आने दो
and
ना.
its
गलती कर दी तो ले लेंगे ना उनकी गलती.
thyrotropin receptor, which is overexpressed by fibroblasts and B and T cells, and its
हाँ,
antibody. All of
मधुबनी
these form
मधुवंती
complexes that cause
डिससाइनिके.
hyaluronan accumulation and cytokine expression, resulting in inflammation, edema, expansion of extraocular tissues. So,
अपने को क्या, हम अपना काम करते
coming
रहते
to
हैं.
the
DOS people to
recommendations,
kindly
current
mute
general
everybody.
recommendations
Lot of disturbance.
for thyroid eye disease management. Can I continue?
Yeah, please. I think there's some.
So it is suggested to be a completely patient-focused approach with importance of effect of disease and its treatment on the quality of life and the psychosocial well-being of the patient, for which the Grays Ophthalmopathy Quality of Life Questionnaire is a very handy tool because it is disease-specific and validated, recommended in routine clinical practice, and available in several languages. I'm not able to go to the next slide. I'm not able to go to the next slide.
Anyone from the DOS people kindly help?
Hello, ma'am. See, what we can do is we can try and reshare the screen, ma'am.
Okay.
Could you stop the screen sharing? If it's
okay,
then you could try and reshare the screen. And now put it in the presentation mode, ma'am.
Yeah.
Now can you see if it's, yes, we can see it clearly, and I think your slides are moving also.
Yeah. So among the criteria for assessment of thyroid eye disease cases, it is recommended to use the standardized criteria to assess the activity and the severity, and to categorize the disease as active or inactive, mild, moderate, severe, and sight-threatening. For which purpose we have the clinical activity score is one of the criteria. It is useful in identifying active disease, and the slides are moving without me moving them. Anyways, it is useful in identifying active disease and response to immunotherapy. Then there's the NO-SPECS classification, which does help to document disease severity, but it is not able to identify patients with active disease. Then we have the UGOGO classification given by the European Union, where we look for presence or absence of symptoms and signs together with a comparative atlas. So we can assess inflammatory signs to identify active phase patients who are more likely to respond to treatment. Again, I can't move the slide.
Ma'am, it's all okay from our end.
Ma'am, please click on center, ma'am.
Center.
Yes.
Just a question, ma'am. Are you using a phone to share the
No,
slide?
I'm not. No, I'm not. Next is the visa classification, which assesses for severity patterns in terms of symptoms and signs, and also helps to assess disease activity. So it is recommended for the treatment to be done at specialized centers and under specialist care in centers which provide endocrinological and ophthalmological expertise, except for the mildest of cases. Recommended guidelines for supportive treatment include that all patients with Graves' disease, irrespective of presence and absence of thyroid eye disease, should refrain from smoking, because smoking is the strongest modifiable risk factor. Euthyroid status should be ensured as early as possible. Lubricants for ocular surface, elevated head posture to reduce orbital congestion, sunglasses to reduce light sensitivity, and prisms for diplopia are also recommended for supportive treatment. Recommendations for steroid prophylaxis: radioactive iodine-treated patients who are at high risk of progression or de novo development of thyroid eye disease, they should be given oral prednisolone prophylaxis with daily dose of 0.3 to 0.5 milligram per kg body weight. The low-risk patients can be given a lower dose of prednisolone, and the inactive thyroid eye disease patients can safely be given radioiodide therapy without steroid cover. Recommendations for management of ocular surface disease includes evaluation extensively and treatment for any ocular surface disorders. Throughout the course of disease, the patients should be given non-preserved artificial tears with osmoprotective properties. Significant risk factors for ocular surface damage include exophthalmos, lagophthalmos, palpebral fissure height, lower lid retraction, lacrimal gland involvement, or MGD. Prevalence of dry eye disease in thyroid eye disease may reach up to 65%, and it is more common and more active and more common and more severe in the active phase of disease. Recommendations for mild thyroid eye disorder: the general measures as described earlier, plus control of risk factors. The major risk factors include smoking, diabetes, advancing age, stress, Hashimoto's thyroiditis. And if the impact of disease still outweighs the risk, we need to consider immunosuppressive therapy for active disease or rehabilitative therapy for inactive disease. Coming to the role of selenium, a 6-month selenium supplementation is recommended for mild thyroid eye disease. The mechanism is decrease in anti-thyroperoxidase antibody levels. So it improves the ocular manifestations, improves quality of life, and prevents progression of thyroid eye disease to more severe forms. Coming to guidelines for the first line of treatment for moderate to severe and active thyroid eye disease, high-dose intravenous corticosteroids are to be given in centers equipped to handle the potentially serious adverse effects. Cumulative dose not to exceed 8 gram. Contraindications include recent viral hepatitis, severe cardiovascular morbidity, or psychiatric disorders after ensuring good control of diabetes and hypertension. There are many protocols which are followed for administering intravenous methylprednisolone. One of the protocols is described here, starting with 0.5 gram per week of intravenous methylprednisolone for 6 weeks, followed by 0.25 gram per week for 6 weeks, leading to a total of 4.5 grams. And in worst cases, a slightly higher dose can be used. We need to watch out for response to treatment and any adverse effects. So a watchful monitoring is needed. And in case of any adverse effects, we need to withdraw steroids in favor of another modality. Guidelines for rehabilitative surgery indication is inactive disease for 6 months in cases with significant impact on visual function or quality of life. And the order of intervention, if more than one intervention is needed, is orbital decompression followed by strabismus surgery followed by lid surgery. Recommendations for sight-threatening thyroid eye disease: if there is an exposure of cornea, prompt medical treatment with frequent lubricants and antibiotics is needed. In cases of impending corneal melt or microbial keratitis, it is more commonly seen in early phase of active thyroid eye disease, severe eyelid retraction, and moderate to severe motility restriction. In cases of imminent perforation, a blepharophy, tarsorrhaphy, or emergency gluing, amniotic membrane transplant, or botulinum toxin for lid closure can be considered. In cases of dysthyroid optic neuropathy, immediate treatment is needed with very high dose of IV corticosteroids and urgent orbital decompression if response is inadequate. In cases of recent onset choroidal folds or eyeball subluxation, orbital decompression needs to be done as soon as possible. The role of rituximab in thyroid eye disease, a comparatively newer drug. It is a chimeric mouse-human monoclonal antibody. It is a steroid-sparing agent. It has an important role in cases with side effects of steroids, such as osteoporosis, hyperglycemia, weight gain, hypertension, etc. But it does need large sample sizes, larger studies with emphasis of long-term prognosis before it can be clinically used more often. Role of adalimumab in thyroid eye disease. It is again a steroid-sparing agent, a fully human monoclonal antibody and TNF-alpha antagonist. It may help to mitigate the side effects of pulse steroid therapy, but again, RCTs are needed for establishing it as primary therapy. Coming to the role of teprotumumab and the OPTIC trial, this is a fully human monoclonal antibody. This one is FDA approved in 2020 recently and marketed as Tepeza. This is the first drug for treatment of thyroid eye disease in adults that has been introduced, and it is speculated to have a role in even preventing thyroid eye disease. It works by attenuating signals initiated at the thyrotropin and IGF-1R receptor. So it blocks the pathological immune response in active thyroid eye disease. The results were established by the OPTIC trial, which was a phase 3 multicenter trial which investigated efficacy and safety of teprotumumab as compared to placebo in clinically active thyroid eye disease of moderate to severe grade, where this drug was administered once every 3 weeks for 21 weeks. And the primary outcome studied was the proptosis response, along with a number of secondary outcomes. All outcomes of teprotumumab were significantly better than placebo. The important need for teprotumumab is in clinical practice is that there is no other FDA-approved pharmacotherapy for active thyroid disease, which can be sight-threatening, life-altering, and if left inadequately treated. My screen stopped sharing.
Ma'am, the time is up, so maybe because of that. Dr. Pankaj Gupta, Dr. Urmi, if you could take it forward. Dr. Urmi, we can hear you, ma'am.
Thank you, Bhavna. Thank you for the nice comprehensive presentation. Dr. Seema ma'am, if she is there, I would like her to comment because she's doing a lot of work on thyroid at Shroff Center. Ma'am, are you there?
Yes, yes, doctor.
She's not there. Yeah. Okay. Ma'am, your comments, because I know you are more experienced as far as the thyroid disease is concerned.
Yeah, so as far as the clinical features are concerned, we know that the profile, what we saw in our setup is very different from what the literature says about the Western setup. And most of these studies and the outcome as well as the presentation are based on what has been reported from the Western setup. Important things what we see, at least in our setup, and it might be true for many of you who treat thyroid, is that almost 30% of our patients actually are euthyroid, which is something which is not very commonly reported in our setup. And the classical description that the females tend to have more of fat disease, and it seems to be more prevalent in them. That's probably is not true, because what as many males with thyroid as compared to kind of females, and it seems to be a little more severe in females. In males in terms of severity as compared to the female patients. So that's some, and in fact, the most common presentation when we reviewed our series was actually dry eye disease. Many of these patients, the very early ones, the subtle ones, go unnoticed because they get treated in the sort of comprehensive clinic or in the dry eye clinic at dry eye disease. So as a dictum now, if any dry eye patient, especially middle-aged female patients who is not responding to your conventional treatment, we do get a thyroid function test done. We look for very subtle signs of lid retraction. Sometimes it's so subtle.
Dr. Seema is experiencing some connectivity issues. That's what we could see from our end.
Let's go ahead with the next talk. Dr. Pankaj, please invite the next speaker.
Yes. We've got Dr. Renu Sinha, ma'am. Could you please start our screen sharing? Over to Dr. Pankaj.
I would now request Dr. Sinha to present with,
Good evening, everyone, and thank you. I am the anesthesiologist at RP Center AIIMS, and today I will talk about oculoplasty surgery, role of anesthetist. So, oculoplasty surgeon needs anesthetist much more than the other surgeons in ophthalmology, because there are lots of tumors which are to be done under general anesthesia, and there are lots of syndromic patients who are coming for oculoplasty surgery. And there are some patients who needs urgent surgery because of the lid coloboma or the other problems, such as this child who was 16 days old when he came with the keratomalacia because of the absence of the eyelids. And he was operated the next day, and this was the result. This child was a 1-day-old child who had this proptosis because of the vaginal delivery by the forceps. So he was operated once he was 18 hours old. So oculoplasty surgeon needs anesthesiologist. And because of these patients, we are able to publish literature also to guide others, just like this Crozon syndrome patient. So anesthetist in the ophthalmology practice helps in many things. I will go one by one. There are so many things. That's why if the anesthesiologist is not present, surgeon has to think otherwise to do other things. So choice of anesthesia should not be my choice. It should be a combined choice between surgeon, anesthetist, and patient perspective, all. Because of the oculoplasty cases, they are older and need extensive surgery. So we should see about the comorbidities. The anesthesiologist helps in optimization of the patient for the surgery, even in the general anesthesia or in the local anesthesia both. So as soon as patient is posted for surgery or the surgeon thinks that he needs surgery, then there should be a printed pro forma for the history. So the patients can be identified that who needs further care from the physician or from the specialist. One of the most common problem in the ophthalmology practice is local anesthetic toxicity. It can be overdose, allergy, or intravascular. So I will deal how to decrease this type of problems. The manifestation of LA toxicity increase from prodromal symptoms till CVS depression and arrest. So there are some recent advances which will help to reduce this type of incidence. Age-old technique of peribulbar block is at the inferotemporal region, medial 2/3 and lateral 1/3, which can cause problems. The newer technique is the extreme lateral approach of the peribulbar block, which is given at the extreme. Needle is inserted as lateral as possible in the inferolateral quadrant because this area is relatively avascular, so chances of intravascular toxicity is less. And in that space, you can give local anesthetic of 5 to 6 ml, and it will help in paralyzing all the muscles, including the orbiculus oculi. And you can see as the drug is given, there is a ptosis which is happening, and this block is much more early onset than the medial 2/3 and lateral 1/3, and the chances of toxicity is also less. So please do practice this block. There are lots of videos available and the literature is also available. And there's chances of intravascular injection is less with this. The second supplemental block is medial canthal block, which is given with 26 gauge needle, half-inch needle, which is, this block is given between the medial caruncle and canthus. And then you can read the literature how to give it. The local anesthetic is given 5 ml at this point of time. During the block, one should have IV cannula in place. Monitoring should be done during the block, and one should guide the patient to tell about the warning symptoms such like lightheadedness, perioral numbness, and very typical metallic taste on the tongue, which will tell that the block is going somewhere else, not at the right place. If obese patients are there, head end can be elevated to make the patient comfortable. Patient who are old, then you can place a pillow so that they will not have lumbar lordosis. Some patients are difficult to position because of their comorbidities. So take time to make the position, and take time. Surgeon should also take time to position himself for those surgeries. L-shaped rod is very helpful to prevent the claustrophobia. You can give oxygen supplementation through nasal cannula or through the breathing circuit. The second is, now there are safer local anesthetic drugs are available. We are using lignocaine with adrenaline and bupivacaine, but levobupivacaine and ropivacaine, they are safer if they go intravascular. So these drugs should be used in the West. These drugs are only used. So they are available in the country and they should be used. Safer dose always should be calculated to prevent the overdoses. Then there are many adjuvants which can be mixed in local anesthetic mixture apart from hyaluronidase, such as dexmedetomidine, magnesium, fentanyl, and clonidine. They will increase the onset time and they will also increase the duration of anesthesia. So we don't need to give much more local anesthetic than the required one. Then sedation is also very important because oculoplasty surgeries, they are longer surgeries than other. So nowadays dexmedetomidine is available, which is given 0.5 to 1 mg per kg per hour. And this will help to sedate the patient without any respiratory depression. So this is used mainly for DCRs, and because orbitotomies are usually done under general anesthesia. Then analgesia can be increased by giving perioperative pregabalin 150 mg 15 minutes to 1 hour before the surgery, and they will reduce the post-operative and intraoperative pain and provide little bit sedation also. Then bleeding is one of the most common problem in oculoplasty surgery. So I suggest to use tranexamic acid, which is an antifibrinolytic drug. It is available in the oral, intravenous, subcutaneous, and it can be used topically also. For oral use of tranexamic acid, 1 gram 2 hours before the planned surgery or 650 mg night before on the day or next day after surgery. Maximum of 1 gram TDS can be given. Intravenous dose is 500 mg pre and post surgery, and it will reduce the bleeding drastically for the cases. I found some literature of subcutaneous Trenexa, which is 100 mg per ml, and it is mixed with 2% lignocaine 1:1. So subcutaneous tranexamic acid is given for the upper lip blepharoplasty, and they are also given for minor oral surgeries, such as if you want to take mucous membrane graft. There's one case report in which 96-year-old patient who was had evisceration, and even he was having bleeding 1 week after the surgery. So the gauze soaked with 2% Trenexa with lignocaine and adrenaline was able to stop the bleeding. So the patients who are more prone for bleeding even after the surgery, then Trenexa mixed gauze can be used for the to prevent the post-operative bleeding. I found this American Academy of Ophthalmology in which the video was there about Trenexa acid for oculofacial surgeries. So it is being used quite commonly in the West also. So this prevents bleeding drastically. Then the antiplatelet and anticoagulant. I am talking about bleeding. So in the patients who are going for oculoplasty surgery, bleeding is a concern. So whether to continue these antithrombotic agents or to discontinue is a big debate. There are lots of antiplatelets drugs and anticoagulant drugs. Some are newer, which are longer acting. So it should be depending upon for what indication these drugs are started. Stopping these drugs can lead to major morbidity and mortality. So there is a score available by which one can know that there is high risk of thromboembolic event is there if these drugs are stopped, or if these drugs are stopped, whether you need a bridging therapy or not, which cardiologist will tell, but we should also know. There are different studies which have controversial result about the stoppage of antithrombotic or continuation of antithrombotic with regional anesthesia. They say that there are retrobulbar hemorrhage, which is a major problem, is very less, but it should be individualized. I found one literature in which it is written that blepharoplasty has only 0.055% incidence of retrobulbar hemorrhage. Only in DCR they found 0.6% incidence of bleeding, and they say that the risk of bleeding is only 0.4% whether you stop the anticoagulant or not. So if the surgery of eyelid is low risk surgery for bleeding, if it is anterior to orbital septum, if you are continuing antiplatelet or anticoagulant, it is moderate if it is posterior to septum, and it is high risk of bleeding if there is deep orbital surgery. So one can continue the antiplatelet and anticoagulant in a high risk patient if the surgery is anterior to orbital septum. So this decision should be taken with the cardiologist, with what type of anesthesia is to be given and what type of surgery is there. So to conclude, the anesthesiologist helps in identifying the high-risk patient and to optimize the comorbidities. He is having a pivot role in giving good block to provide analgesia and sedation, to reduce the intraoperative bleeding, and to manage the antithrombotic drugs for patients who are on them. And above all, he is always available to treat the medical emergencies at the time of complications. And he can help in ophthalmologist also or any surgeon to work faster. Thank you very much for your time.
Thank you, ma'am. Thank you, Dr. Sinha, for joining us, the ophthalmic fraternity here at DOS. We welcome you. And of course, your role can't be underestimated at all. And we realized, especially during the recent mucor, when we had to do exentration, especially in patients who are high risk with hypokalemia, and we were just after you to get them operated for. So it has very emphasized. And moreover, you are right that out of all subspecialties, oculoplasty is most dependent on anesthesia people. And there are certain surgeries which are clear cut that they have to be done under GA, exentration, orbitotomy, but there are certain borderline also which can be done both under LA and GA. One of them is DCR, I would tell you. Preferably it should be done under GA, but in a government setup like ours in a tertiary, when we have a long list sometimes in the OT and it just can't settle in the GA table, we'll end up doing it in LA and फिर बाद में regret करते हैं यार कोई इसको, because it is definitely more comfortable being done under GA. But yes, LA में भी हो जाता है, but
करके देखिए और डेक्समेड यूज करके देखिए, you will love to do under local anesthesia.
नहीं वो भी करते हैं, but मतलब what I am emphasizing is your role, which is definitely very important for us. Thank you, ma'am. Thank you for being present here.
Place in your setup.
Definitely. Okay, Dr. Pankaj, let's go ahead.
I think Dr. Abjeet is not here. Is Dr. Abjeet Ransal here?
Not yet, sir.
No, we cannot see him, sir.
Then I'll invite the last speaker, our Dr. Pankaj, who's been helping us all through the session. I invite him to deliver his talk on correction of upper eyelid entropion. Dr. Pankaj, over to you.
Yeah, thank you. Is my screen visible?
Yes, sir, it is going to be visible. Could you just put it in the presentation mode, please?
Yeah. So good evening, everyone. I'll be talking about correction of an upper eyelid entropion. Entropion, as we all understand, it's an inward turning of the eyelid margin, and in the upper eyelid, largely it's a result of cicatrization, whether it is secondary to burns or trauma, chemical injury, or a result of conditions like trachoma, which cause conjunctival cicatrization, or a progressive disorder like ocular pemphigoid. Involutionary entropion doesn't affect the upper eyelid. It largely affects the lower eyelid. And apart from cicatrization or any other cause of upper eyelid and entropion is very rare. I'll now show a surgical video of upper eyelid entropion correction. This is actually a combination of two techniques. This 63-year-old female patient presented to us with the entropion of upper eyelids. She had epiphora and foreign body sensation. The tarsus on examination was thickened, and conjunctiva showed a linear scar in the palpebral part. So after giving a local anesthesia, a traction suture is applied so that we can apply traction on the eyelid as and when required during the surgery. Eyelid spatula is placed, and a skin incision, a linear skin incision is made approximately 5 mm from the lid margin. Dissection is done, which is aiming at the suborbicularis plane so as to expose the tarsus. And once the tarsus is well exposed, the dissection stops here. A linear full thickness incision is made using a 11 number Bart Parker knife, which goes through the tarsus, as we can see here. And thereafter, a small wedge, usually 1 to 1.5 millimeters, or a maximum of 2 millimeters of the tarsus, a horizontal wedge is excised. Thereafter, the tarsus is closed with interrupted 60 Weichel sutures. And now that the tarsus part is done, the next is the anterior lamella, which is the skin and the orbicularis. So now, before we can close the anterior lamella, we need to excise any redundant tissue, any redundant skin, which in this patient was required. And then the skin and the orbicularis are then sutured. And whenever this bite is taken, the upper tarsus is also taken along. The lower tarsus in this suture is not taken, only the upper tarsus, so as to have the effect of tarsal rotation. So this technique actually is a combination of wedge resection of tarsus as well as a tarsal rotation. So at the end of the surgery, as we can see, the eyelid margin is well everted. There is no more lash globe contact, and the contour is also normal. So that's all that I had to say in this presentation. If there are any questions or comments, thank you.
Thank you, Dr. Pankaj. It was a nicely done surgery. Actually, entropion can be operated in a number of ways, and the surgeon should get used to the best way he or she can give good results and follow that, and it really works because you have to modify the technique according to your own results. So it was a nice presentation, the standard procedure that you did. It works really well. Thank you so much. And it has been a very long evening of oculoplasty today, starting from 4 p.m. So, and I think most of the panelists have left due to, I don't know. And Dr. Seema ma'am is here. I thank her and all the other panelists, Dr. Niba ma'am, all the speakers who are there. Thank you for your wonderful talks. And Dr. Seema ma'am, your talk was very nice. I couldn't comment after that. It was a little late, but your center is really doing a wonderful job, and the innovative instrument that you told, that is really very helpful for screening, I think, and must be so gratifying for so many parents whose children are detected, and it's so life-saving for them. So it's really, ma'am, really wonderful job being done by you and your institute. Retinoblastoma is something really we need to work upon so that it can be helped. Ma'am, your comments before we end the session.
Thank you very much. I think it's just a few.
Dr. Seema ma'am, are you connected?
Can you hear me? My network is little poor.
I think there is some network problem. Anybody wants to say anything? Dr. Manu, Dr. Gaur, Dr. Niba ma'am, Dr. Pankaj.
Dr. Seema, we've lost you again. We can't see you. So,
yes, ma'am. Now.
In the meanwhile, I would just request the other panelist. I could also see that Dr. Seema Das is facing network issues. So if you could.
Yeah, I think then we can sum up. Anybody wants to say anything? The most speaker? Otherwise, we sum up.
We have finished 3 minutes before time. So yes, this is the time. Can I request all the panelists, all the people available over here to please switch on the camera? Maybe that would help to take a screenshot at least.
Yeah.
Atul from the Grover EV team, could you take a screenshot or should I take the one? But it's only 5 of us.
Never mind.
Dr. Gaur and Dr. Niba Anand, can you switch on your camera, please? All people who are present here. I think people are not there.
So this is what happens in an online virtual event where people are omnipresent, where they are actually there but not there.
Yes, exactly right.
Proxy attendance, you can call it.
Yes, exactly.
I don't think really the screenshot would really make a difference.
No, it
but
won't. Just for fun's sake, nothing.
But I would like to thank Dr. Pankaj because he's been with us since the beginning. And thank you so much for.
It's 4 p.m. So I'm
yes, ma'am. Yes, ma'am. But yes, ma'am. Thank you so much, Dr. Urmi Chawla, ma'am. Also, Dr. Seema, apologies for the connectivity. कुछ चीजें हमारे हाथ में नहीं होती हैं. So I hope you understand, ma'am.
Thank you very much.
Thank you, Dr. Manu, also very nicely presented.
Thank you,
and
ma'am.
Thanks for waiting till the end. Most of us have already left. Thank you so much.
And we've got Dr. Manu's princess right behind her also. She's just looking.
Yeah.
Please, Romi.
That's a wonderful thing.
Nikhil, I would just correct. I'm Dr. Urmil. I'm not Dr. Urmi.
Sorry, I'm really sorry,
No,
ma'am.
sorry. I just up to we are on a casual mode, so I can just tell you that I'm Dr.
No
Urmi.
problem, man. Thank you, Dr. Urmil.
Okay.
We've got from the Ashoka Hall. We've got sir joining in. Yes. So
joining से हमारा
Hello, Dr.
कामयाब हो
Urmil.
गया
How are
session.
you?
Good evening, sir. Good evening.
Good
आपके आने
evening.
से हमारा
Pankaj, how are
session
you?
कामयाब हो गया.
Seeing you
Fine,
after a
thank you,
long
sir.
time.
हाँ जी सर.
सर आप तो बहुत थक गए होगे, अब आप रेस्ट लो थोड़ा.
मैडम अभी से थक गए.
Dr. Urmil would agree that इनके आने से अब हमारे हॉल में 4 चांद लग गए हैं, है ना?
बिल्कुल. मैं सिर्फ आज के लिए थकान कह रही हूँ सर. कल से आपने फिर वही रिजुविनेटेड होके सुबह 5 बजे शुरू हो जाना है.
हाँ जी.
Hats off to you, sir. Hats off to you.
So it was excellent session. I was listening in between.
नहीं sir. Thank you so much.
So I would like to thank each and everyone, all the chairpersons, panelists, and delegates for attending this excellent session. And thank you. And the main conference is from 1st to 3rd October, and on 2nd it is live surgery. So I would invite each and everybody to join. Thank you very much.
Thank you, sir. Thank you to you for making DOS always a very big and pleasurable event to attend. Thank you so much, sir. It is always looking forward to DOS. Thank you so much. Good night.
And
good night, everybody. Good night.
On behalf of everybody present over here, we would like to thank sir for joining in at the last minute, because as I said, last minute में भी sir आए, लेकिन 4 चांद लगा के गए. Thank you so much.
पहले से ही था यहाँ.
अरे सर, लेकिन आप जब बोलते हो तो तब अच्छा लगता है ना सर.
वीडियो पे
हाँ.
सर जब आपने चेहरा